is the first such workshop of Allied Sciences. And with the tradition of RP Center, it's always been Dr. Rajendra Prasad Center for Ophthalmic Sciences. It's not simply an eye institute or an eye hospital. So it's very important that we remember that it is the entire gamut of ophthalmic sciences which supports our best patient care now and for the future. So without further ado, I'll invite our co-chairpersons to please come on the dais. We have Dr. T. Velpandian, who is a professor and in charge of ocular pharmacology. And from the Department of Pharmacology, we also have Dr. Nabanita Haldar. I'd invite her also to come on the dais for the first session. And along with that, I would now request Sir to say a few words of introduction for the workshop.
Yeah, thank you, Dr. Radhika. Am I audible?
Yes, sir, nicely audible.
Okay, thank you. And very good morning to all of you, especially people who have come physically for this very, very interesting workshop, and people who would have joined us through our various links of our workshop, which is being done in RP Center for so many years. And I'm very happy that we thought about doing this unique workshop of allied sciences. As Professor Radhika nicely highlighted, we are looking for a very comprehensive, can say, exposure of people in a different aspects of ophthalmology, and that includes the important area of supportive, you can say, sciences, which is basically, as you note in our subsequent lectures and demonstration in the various labs of our center, right from the pharmacology part to biochemistry, pathology, and microbiology. They are a very integral part of our ophthalmic clinical practice in terms of patient care, research, and teaching wise. And I'm pretty sure this is one of the unique workshops in the country where people will have access to these areas, not only listening to our expert faculty members of RP Center in these various departments, as well as seeing the labs where we do such a wonderful work being done by our faculty in these areas. And apart from that, we have incorporated the clinical aspect of these areas also. So our clinical faculty will also contribute the clinical application of these basic departments in our day-to-day practice. Now, again, very, very happy that today we have this workshop, and sure that apart from our resident doctors, the other people who have come from various parts of the country and the people who joined us, they're going to enjoy this. And I'm pretty sure they'll have a lot of queries. They should always ask questions to our people. If they have email address of us, they can text the question to us and we can answer them. Thank you again. I wish you all the best for entire faculty, right from the Dr. Radhika agreeing to chair this particular session of basic allied sciences, and all the faculty of basic allied sciences, right from the pharmacology, ocular biochemistry, ocular pathology, and ocular microbiology. Thank you again. I wish you all the success. Thank you again.
Thank you so much, sir, for those encouraging and inspiring words. So we can now start our session. The first one is on ocular pharmacology, which is the foundation of all our medical therapeutics. I'll invite Dr. T. Velpandian to give the first talk on pharmacokinetic principle in ocular therapeutics.
Good morning all. Thank you very much for inviting me for this first lecture on this workshop. I would like to dedicate my lecture to my mentor, Professor S.K. Gupta, who is supposed to be the first founder of ocular pharmacology in India. And he was heading our division of ocular pharmacology. Recently, he expired. So, but in his memory, I thought the best thing to dedicate today's lecture of mine to him. The most important achievement is that is the first department of ocular pharmacology made in India to especially or to specialize in ocular therapeutics. It was about 30 years back. Ophthalmology was considered only as a surgical discipline. When pharmacology came in, it was a visionary. It was a vision of Professor L.P. Agarwal, who brought pharmacology inside. And see, look, this important contribution of him is that in 1988, first eye drop, that is norfloxacin 0.3% eye drop, was made and tested in animal and was introduced. In 92, Professor Vajpayee, these two papers are very important papers in the history of pharmacology in India and first, in fact, in the world also. Many people followed after this. After that, we had norfloxacin, ofloxacin, pfloxacin, iplofloxacin, moxifloxacin, gatifloxacin, all floxacin. So all thing, it just started this way. Ever since, the ocular pharmacology has been involved in just, bringing the new therapeutics into ophthalmic practice. So in this case, I thought it's better to just talk about pharmacokinetic principles in ocular therapeutics. There are many questions remaining in ophthalmology to be answered. Number one, why we are not having so much of drugs in ophthalmology? Simple topical medication on eye drop. Everybody knows an eye drop for eye disease, but we know very well that may not be good for retinal pathology. So why so? Why is it not going inside? Well, all our colleagues from other departments in emergency medicine, when a road accident victim went to the clinic, immediately they trust on two things. One is their surgical skills. Number two is antibiotics. But when it comes, the same thing comes to ophthalmology, we have a problem. We cannot rescue them with an antibiotic because we know that antibiotics won't penetrate eye. So see, when we started work on these areas, we had a lot of challenges in front of us. Today we understand much more about eye from pharmacokinetic point of view. Stage by stage, we took things further to get this knowledge. Today, I'm just going to give you a broad overview about it. So the thing is that if we just look at a gross picture of everything, say the drugs which are developed for eye or any clinical trial for the eye, which is less than 1% when it comes to US FDA clinical trial is concerned. This is one of the snapshot data we got it. So the drugs which are approved by US FDA, that's very, very few drugs when it comes to the gamut of, all therapeutics, the drugs which are in therapeutics. Take a Goodman-Gilman. It was, which later stage in 1995, ocular pharmacology was introduced. Before that, there was no ocular pharmacology. So that amount of clinical trials, the type of drugs which are developed are very minuscule to such an extent today, even today we are using atropine, which was having, is as having time immemorial, and it has been used from ancient days. So I just wanted to tell you an important failure, right? The best thing is that sometime when you look back the failures in clinical trials to understand things much better. So the one of such trial is Memantine. See, this is a very interesting trial. In 2008, this news appeared, Memantine, the day of the music dead in glaucoma. See, the glaucoma, we always talk about neuroprotection in glaucoma. So, what is this drug Memantine? Memantine is a drug, which has been approved for neuroprotection in case of CNS diseases or different conditions, age-related conditions like Alzheimer's, or Parkinsonism, etc. Always, it is something like if a drug fails in the clinical trial, which is just kept in the shelves, it never comes to public domain. So this is what the whole story about it. After that news appeared on the Memantine, our curiosity went on to understand what went wrong. Sometimes you understand that, the flight crash investigations, 2 seconds before that accident, what has happened? 10 seconds before what has happened? Something like, when we started understanding, we came to know many things. See, the drug is not a bad drug. It's a good drug. It's approved for Alzheimer's, Parkinson's, Huntington, or amyotrophic lateral sclerosis, vascular dementia, CNS trauma, ischemia everywhere. If I consider blood-brain barrier equivalent to blood-ocular barrier, then I expect the drug to act. What went wrong? Something, which is very interesting. We took up this work and started studying what went wrong in that. So it's all something to do with pharmacokinetics. So what happened is that this is something which came up. That is a single dose of 20 milligram of Memantine when it is given, and it has reached a Cmax of 0.14 micromolar at the Tmax of 6.9 hours. So the clinical trials which went on, especially there was one study which came in IOVS, which talks about Memantine in monkey model, which we just looked very carefully. Just many data from the pharmacokinetic parts are hidden. So when we just took up this work and we just went on extrapolating it, and we got some more information, how much it penetrates the CSF is about 0.55. That's what they call the ratio between plasma versus CSF penetration. So when 0.55 was proposed in human, how much was proposed to prevent the neurotoxicity was 1 micromolar. So this drug never reached 1 micromolar concentration inside the eye. Therefore, it could not be. It failed in clinical trials. As a result, billions of dollars, public-funded money, has gone. So sometimes, when we try to look into it, therefore, when the editor of this journal, Drugs in R&D, asked me to write a commentary on this part, what went wrong, I just put it up in this way: closed gateways can neuroprotect the retina in glaucoma. So something like, we know very well that no, it cannot happen in that way. So this is what about it. So eye is protected by barriers: anterior barrier, posterior barrier, cornea itself a barrier. So now our understanding is much more. Now we understand that what type of drugs can be taken from systemically, can reach eye through tear film. But this knowledge was not existing those days. Our contribution was very significant in the understanding about ocular therapeutic in the world. So something like, blood ocular barrier, in which you divide it, blood retinal barrier, again you divide inner blood retinal barrier, outer blood retinal barrier, then it's just blood aqueous barrier, where you are having an iris and ciliary body. Then we come to cornea. The cornea is having. So what is this barrier? See, the barrier immediately, when the word barrier comes in, immediately you start thinking that there is something like a fence. But see, this is not fence. It is not a physical barrier. It is much more smart. It's all smart puts. The eye decides what to go inside, what not to go inside. Your intestine decides what to go inside, what not to go inside. That is why after giving anti-cancer agents, if you give them orally, it will not be taken up. Many of the agents, like aminoglycosides, will not be taken up. Why? There is a reason behind it. They are all like what we call it as drug transporters. The smart ports are called drug transporters, and they decide what to go inside, what not to go inside. In the cornea, carnal epithelium, pharmacologically, when I look carnal epithelium itself is having several transporters, apart from zona occludens, which is tightly packing the carnal epithelial cells. Apart from that, corneal endothelium is having transporters. That transporter is responsible for even bringing glucose to corneal epithelium for its survival, because you cannot have a glucose coming from tear film to avoid corneal infections. The physiology is so beautifully designed. Eye is well protected from all sides. I always call eye is not a simple organ. It is an island, and all ports are governed. All things are protected. You can't just take it for granted everything will go inside. So I wouldn't say that, eye is like a parasite. But evolutionarily, we adopted a synergy through that, and it is an organism living with us. Mutually, now it started adjusting. So it has a ports, it has got, to such an extent, I would like to say, very well that renin-angiotensin system, all of you know it exists in kidney. Do you know it exists in retina? So you know that renin-angiotensin system is in the excretory system, that is kidney, it is existing in the retina. So retina is also behaving as a excretory system. There is an absorption port, there is an excretion port, so there is some amount of metabolism, there is some amount of distribution, therefore I call it as an organism. So there is nothing wrong to think like that. So that's how, when we try to look into even drug delivery systems, several drug delivery systems, they cannot cross the cornea. They're stuck at corneal epithelium. Even hydrophobic drugs, they stuck in the corneal epithelium, unless otherwise they have enough lipophilicity or hydrophilic balance, they cannot penetrate cornea. So corneal penetration is highly governed by such type of things. So even when we just look into the infection site, say again I'm telling you, there are only few agents which are used intravitreally, not every antibiotic. Have you ever asked the question why? I have the answer. And it took such a long time for us to answer this question, and we answered the question, what was observation made about 40 years back? That gentamicin is excreted through anterior route. The reason for excretion through anterior route was first established by us. So how it is going out. So if an infection goes inside the eye, you have to go stage by stage, because you know very well, eye is the immunoprivileged organ. You don't have first-line defense mechanism. So, and the eye will never come to know unless otherwise the bacteria reaches quite a good in number. So the toxins started disturbing the barriers, then inflammation comes in. Even today we have some more good information to say, and the inflammation also, there are transporter changes in the eye. Don't think that the moment the eye is infected or the barrier is breached. It's not so. This is what conventionally been taught. So even now we know, in case of disease condition, even in case of uveitis, what type of changes are happening. There are changes happening. In uveitis, selectively if you are treating uveitis, you are able to recover the vision completely. So if so, barrier breaching, how the barrier is closed. So there is some sort of a transporter alteration, what you call as barriers, and some of them are turning against us. So now understanding more and more is coming up. So we did a lot of work on antibiotics. See, basically the time has gone about 20 years back. We put a lot of energy to understand that which antibiotic goes inside the eye. Now today we know very well that we don't have to look into it. I would say which type of antibiotic, you look at a structure, I would be able to say this will go inside or not, because we have that much of amount of information. All this work started earlier because when we injected fluconazole inside the eye of a rabbit, it took only 3 hours for the fluconazole to get excreted from the eye. So the question started, what went wrong? It was a paper which published in 2000, 22 years back. That was the first fundamental paper which started understanding about the presence of transporters. So I'm going to show you, I just want to cut short many things. I'm not going in detail about it, but I wanted to say that how I show you that how these transporters are functioning. See, the obvious question is, pilocarpine you use 1% to 2%. Or, but when it comes to moxifloxacin, you use 0.5%. But when it comes to latanoprost, you use 0.005%. See, the difference is 100 to 200 fold difference in the drug concentration. You are putting topical as an eye drop, but what reaches there inside is something different. So now the question comes, what makes a drug to penetrate, what not? So there comes their individual character or substrate specificity, which makes them to go inside or not to go inside. So to go more in detail about it, see, just for your understanding, I would like to say, a single drop of voriconazole, if you put it, see, this is a basic fundamental paper of voriconazole pharmacokinetics. Based upon this, our lab got the permission for filing voriconazole for topical use. So this work has been done in collaboration with Arvind, this voriconazole done in human. And after repeated administration, when you do 1 drop every hour, you see the concentration, how much it is reaching inside the aqueous. Whereas if you put 2 hours, how beautifully it is going, you see that? So this is how that it is trying to reach. So this is how that individual pharmacokinetics gives us so much of information to us, that what type of dosage to be given, how frequently it is to be given. So I always tell my students that never allow the patient to put 2 drops, it's always 1 drop. The lower phonics, put only 1 drop, ask the patient to close the eye for 1 minute. That will increase a good bioavailability than 2 drops. 2 drops will cause only tearing or reflex tearing, it will go off. So just, these are all the studies we have done by using all type of thing. So just this illustration will tell you quickly about what is the end of those studies we have done. When you give a substrate of which is like a fluconazole intravenously, what happens is that immediately it gets equilibrated with 2 types of tissues, what we call pharmacokinetically a rapid equilibration tissue and a slow equilibration tissue. The moment we give a blocker of that particular PGP, which is substrate for fluconazole is a substrate for PGP, this compartment, slow equilibration compartment, goes off. What is this slow equilibration compartment? Is everywhere this is present, PGP is present, which is resisting the organ from reaching good concentration. That is why the drugs which are susceptible for PGP won't reach brain, it won't cross blood-ocular barrier, it won't cross other places. So these things can beautifully be explained by this. And now when you just get inside more, when you inject directly intravenously, intravitreally, I just take another 2 minutes more. Intravitreally, again the intravitreally injected drugs, they're just getting pumped out through retinal barriers. The barriers are again filled with this kind of transporters. So that there are several types of transporters. We have organic cation transporter, we have organic anion transporter, we have peptide transporter and PGP transporters, in which we know today very well the substrate for PGP OCT, that is organic cation transporter, is which are positively charged. The positively charged compounds can stay, if you are giving intravitreally, for longer duration than any other compound. If it is organic anion transporter, if you give penicillin inside the eye by intravitreal injection, it just excreted like that. You know, there are a lot of studies happened. You know, when penicillin was, along with penicillin, probenecid was tried to increase the bioavailability. That did not increase the bioavailability in the eye. But therefore, it is decided that there is something wrong in the eye. There are a lot of Payman and Berman papers, but old papers, 1980s papers. And it took such a long time for us to reveal that. Why so? Where they are present, how they are responsible, where are they expressed. So now we know very well how they are going to handle it. So how much time I have got more?
Time is up, actually.
So, thank you, ma'am. So what I want to say in nutshell is about, we have all ocular barriers, all smart ports. They have drug transporters, and that drug transporters decide what goes inside or not, and they are responsible for pharmacodynamic activity, what you are expecting it to be. If a drug is having a very short half-life inside, you don't expect it. If an antibiotic is not reaching MIC90 inside, it's not going to kill the microbe. Therefore, it is always important. Pharmacokinetic mediated understanding of a drug is very important for knowing more about the fate of the drug inside eye. Either you give topically, intravenously, or give intravitreally. This is what most important one. Thank you very much, ma'am, for giving me this opportunity. I think.
Thank you, Dr. Pandyan. It
Yes,
was
ma'am.
very beautifully expressed, a huge lot of information encapsulated in few minutes, and extremely important and relevant for clinical applications. Thank you so much. And now we go to another very important aspect of ocular pharmacology, that is the preparation and dispensing of non-commercial ophthalmic preparations. For that we have Dr. Anna Benita Haldar. We won't take questions right now because there's lack of time, and everybody would like to hear all the wonderful information that you're going to hear from the faculty. If there's any pressing questions, we can take it at the end.
Thank you, ma'am. Respected chairperson, faculty and members of the audience, a very good morning. So we all know that RP Center, it is one of the best place for critical eye care, ranging from handling the ocular emergencies to various critical conditions involving the anterior segment and the posterior segment. And there are many factors which are contributing to this center of excellence to maintain its glory throughout since its inception. And one of them, I must say, that having in-house GLP compliant ocular compounding and dispensing facility. So this facility is not there in any one of the medical institutes in our country. So that's why RP Center is unique. And this is present in Ocular Pharmacology Division, and it is active for the last more than 2 decades, as Professor T. Pandian has already told you. And we are compounding and dispensing more than 25 different formulations, topical as well as biologicals, injectables, to the patients who are coming to the center for the treatment. So before going to the title topic, that what is exactly going on in our department, so I would like to focus on certain factors which necessitate the extemporaneous dispensing of the drug formulations. So as you can see that when there is a small market size of the drug, so the the pharmaceutical company, they are not very much interested in paying attention to develop the formulations and its innovations. Then the drug stability, it is a very important issue. I will be coming in my next slide. So there are various drugs which are pharmaceutically unfavorable, and they have a very short shelf life, so not available commercially. And then off-label use of the drugs like bevacizumab, we are using it for the diabetic retinopathy and age-related macular degeneration. So, and then sometimes the concentration which are available commercially is not found to be effective. So there is a need for making higher concentration of that particular patient. Then there are many other factors like endogenous biologicals, which they have to be prepared fresh on the same day from the blood of the patient. And then when there is a need for changing the routes, and then there are certain region-specific requirements, and when there is a drug for the rare disorders. So these are the different factors for which this extemporaneous drug compounding is required. So now coming to another very important point, the stability of the ophthalmic formulations. And this stability of the drug should be present from the time of preparation till its use over the period of time. And there are many components which affect this stability, starting from the physical, like the clarity of the drug, the physical appearance, the chemical stability like pH, the tonicity of the drug, then the condition of preparations, the type of containers where it is packaged and placed, and then the storage condition is very important, where because it has to be done under completely sterile condition, and then the biological stability, which is very important. And so there are few key points we have to remember for this compounding and dispensing facility, that ophthalmic formulations which are required to be sterile until it is opened. And then secondly, the repeated opening of this multi-dose container also adversely affect the chemical stability of the drug. And then the unpreserved formulations, because sometimes patients, they are allergic to the preservatives. So we sometimes prepare preservative-free formulations, so they have to be consumed in a couple of days. And then the stability of the extemporaneous formulations must be well documented. Now, this is very important, that ophthalmic compounding facility, this of drugs which are used for this ophthalmic therapeutics, they need to be done by strictly following the US FDA guidelines. Because these ophthalmic preparations, I will show you our facility, it needs to be done under sterile conditions with expert pharmacist, and then there should be a perfect balance between the formulation characteristics, as you can see here. As I have already told you in my previous slides, the pH, tonicity, viscosity, these are very important, and which has to be with the perfect balance with the qualified, the availability of the sterile conditions, and the qualified and expert well-trained pharmacists, and then the aseptic handling, which is very important when someone is going for this compounding. So these are the commonly used extemporaneous drug formulations which are available across the world, and they are various antibiotics for different indications with various dosage strength. So this, you can see our facility. This is completely GLP compliant. And as you can see that this facility is completely covered by centralized HEPA filter, which maintains the air dynamics, and they are very efficient to remove the particulate matter which are more than 0.3 microns. So, and this is highly sterile zone, which is class 10 facility according to the ISO classification. So where we are making the injectables. And as you can see that these are the few topical, like representative topical formulations, mainly ranging from different mydriatics, meiotics, and different concentrations of antibiotics and NSAIDs, which are regularly we are supplying to our OPD. And then there are few agents which we make extemporaneously with on the request of the special need by the clinicians. So, and these are the injectables. We are making ampules. As you all know that bevacizumab we are dispensing in 200 microliter of ampules, so that the patient, they just have to pay 1,500 rupees for each injection. So these are the list of drugs which we are making for the patients who are coming here, and this is the number of vials which has been consumed in the last financial year. So this is another initiative by Ocular Pharmacology Division with Ministry of Health and Family Welfare to enable the corneal transplantation throughout across the country, and we are mainly supplying the government eye banks. Presently, 94 eye banks are receiving this MK media to enable the corneal transplantation, and we have transformed from MK media to the longer storage media that is called Extorsol, and again using the same high sterile facility we are dispensing this MK media. So I will be happy to share some recent developments which happened, which is related to this extemporaneous drug compounding, related to this extemporaneous drug. So that is natasol. Natamycin, you already know that there are certain challenges in treating this deep corneal keratitis with the conventional drug natamycin, because it is absolutely poorly soluble poorly insoluble in water. So we have prepared Natasol, which is like pharmaceutically we have manipulated so that it is more water soluble, and it has shown very good result in preclinical and the clinical studies. So this is another development, that is Natamatrix. It is an implant which is carrying natamycin and will be continuously releasing natamycin at the site of action over the period of time. So the high concentration will be achieved, and this is placed in the stroma. And sorry. So as you can see from here, this has been shown promising result in animals, experimental animals. The clinical study is yet to be done. So another aspect of extemporaneous drug formulation, it is very much useful to handle the ocular emergencies. The medical treatment for ocular emergencies, they require the specialized off-label use of drugs, which are not available because of their physical instability and the shorter half-life. So, and then this corneal injuries due to the chemical exposure, acid-alkali burns and trauma, it is very much prevalent in our country. So it is really a challenge in primary and secondary level hospitals to deal with this kind of ocular emergencies because of the lack of medication. So here in our center, we have overcome this kind of challenges because of having this facility, because we can supply this off-label drugs extemporaneously prepared whenever the patient, they are coming to our eye casualty. So as you can see that that's why, since this facility is only available in this tertiary care hospital, the patients from various states, from far off distances, they travel and they come to our center to get the treatment when there is ocular emergency. But by the time they reach to our center, they already lose the vision and they might lose the eye. So I have enlisted a few conditions where the delayed treatment has it has resulted in so many permanent loss of vision. So our division has come up with a small portable device that is known as TransRecon, which basically acts as a connector, like by understanding the unmet need of this emergency medication. So this has been designed with the help of 3D printing technology, and this is a very unique device which can reconstitute, which can transfer and reconstitute the drug with the appropriate diluent. As you can see that this is very easy to use and it does not require any expertise. So you have to just connect the two vials. One will be carrying the appropriate diluent and the other one will be having the drug in the powder form. So you have to just cap in the two end of this TransRecon and just you have to shake it, and like before shaking you have to press the diluent container so that the 100% of the diluent, it comes to the bottom container without compromising the sterility, and this is instantly prepared formulations which is ready to use for any ocular emergency. So this has been developed with the help of Biotechnology Ignition Grant, and the principal investigator being Professor T. Velpandian of our department, who is the in charge. And with the help of this grant, so this TransRecon technology has been very successful, and very soon it will be commercialized, and it is expected to bring such revolution in ocular therapeutics in future. And we are also experimenting many appropriate diluents which can increase the shelf life of the drugs when it is instantly prepared. So this Ocular Emergency Kit has been launched this year only on the day of on the RPC day. So this is with the help of this TransRecon. We are many eye formulations in the solid and the semi-solid form can be available in the kit, and with the appropriate solvent, and there will be the TransRecon devices also. And these are the drugs, they are very much stable in the room temperature, and they are packaged in sterile conditions in GMP certification lab. They are highly economical and they're easy to carry. So this will be very much beneficial to the patients who are living in rural areas, and this will be available when it will be commercially available. So the primary and the secondary healthcare center, they will be benefiting a lot, and they can handle this ocular emergencies very well with the help of this kit. So we have sodium ascorbate, sodium citrate, PHMB, and different other antibiotic formulations which are not available on the shelf. So this kit is really going to be useful in different conditions where instant formulation can be prepared without any expertise. So this is our team, Ocular Pharmacology team. I'm sorry, like apart from these members, we have 5 pharmacists, well-trained pharmacists which are working with us. I'm sorry I don't have the picture. So thank you very much for your attention.
Thank you very much, Dr. Nabonita. That has given a very good insight into the tremendous amount of clinical service which is being provided, and has also shown how innovation and use of scientific methods can give you the cutting edge, as well as you can be the leader in the field. So we really rely a lot on this excellent service that we have, and we encourage everybody to appreciate and also give feedback if you feel there is any other product or any other futuristic views that you have in this area. So thanks a lot. That was really inspiring. And now we come to another very important aspect, that is targeted drug delivery in ophthalmology, the clinical applications, by Dr. Prafulla Maharana.
Good morning, everyone. So since morning you heard from our basic scientists how things works in pharmacology, but being surgeon, what we do, we start with topical drops. If it doesn't work, increase the strength. Still not working, add oral medication. Still not working, give IV. Still not working, give all of them together. Still not working, go and inject where it is required. So this is what in layman term we call a targeted drug delivery. But when you combine that with some scientific approach, and fortunately, as ma'am highlighted, we have our Dr. Velpandian who always there to help us in these things, then it's known as a targeted drug delivery. So this, what is that? That is means the targeted drug delivery means it's a selectively and preferentially delivering the drug where it is required or the target site. What are the advantages? Increases bioavailability, because you are giving the drug exactly where it is required, so availability is much more. Reduce toxicity. If the drug is more toxic and can damage the adjacent tissue, it's better to inject directly at that site. So usually targeted drug delivery is there for toxic drugs and drugs with short half-life in systemic diseases. And currently nanoparticles, and specifically in oncology, where highly chemotherapeutic drugs are there, that is used there. So targeted drug delivery in ophthalmology is predominantly in keratitis, then endophthalmitis, then some ocular tumors where bleomycin and all this thing is injected directly, and retinal disorders. I'll just go through few videos showing some common approaches of targeted drug delivery. This is a paper we published in 2020 in Survey of Ophthalmology, where we discussed this targeted drug delivery in detail. If you people are interested, you can go through that. So what it does is it ensures adequate drug delivery to the site of infection. One important part is in patients with poor compliance, where it hasn't been explored at all. If the patient is not putting topical drops, you can use this method if the ulcer is not healing. And the advantage I have already told, you are giving a very high concentration at the site where it is required. So most commonly from, I'm being a cornea person, my experience is on intracameral and intrastromal use of antibiotics in microbial keratitis, as you can see in these images. The commonly indicated situations are when you are dealing with a deep keratitis, the stromal involvement is more than 50%, and the penetration of drug is not that adequate to reach the site of infection. Recalcitrant cases, we have tried all the method, as I said, but it's not working. And when there is severe interchamber reaction, this third one is specifically for intracameral injection. So these are the different drugs that have been commonly used, And to that list, I would like to add natosol, which Dr. Navanita has highlighted. Even we did a thesis about that. So amphotericin B, voriconazole, and recently there have been reports of using vancomycin intrastromally in cases of post-DSEC infections. So this is how it is done. Amphotericin B, the concentration is 5 to 10 microgram per 0.1 ml, but you may have to repeat it after 72 hours. The problem with voriconazole is it just survives for 22 minutes. The T-half is very less, so you may have to repeat it more frequently compared to amphotericin B. This is a short video how intrastromal voriconazole is injected. As you can see, it was a case with infection in the antechamber as well as a stromal infiltrate. You can see here, this is the stromal infiltrate, this is the AC exudate. So a combined intracameral and intrastromal injection was attempted in this patient. So first you make a paracentesis, and then you try to remove all the exudate from the antechamber. I have skipped that part. It was done using a bimanual cutter, bimanual vitrectomy cutter. So once that is done, then this is how intrastromal injection is done. The trick is you have to start from the normal area using a 30 gauge needle and take it till the edge of the infection or infiltration and try to achieve, as you can see, some hydration with the antibiotics. Then you have to repeat it because you have to surround the infiltrate from 360 degree all around. And one important thing to remember is each time you are going in, you have to change the needle. If you use the same needle again and again, then you may create one more foci of infection in your normal cornea. So this is how it is done. You have to create a barrage all around the infiltrate as it is being done here. Once this is done, then you can hydrate the wound and inject some intracameral antibiotic, which could be voriconazole or amphotericin B. So this is one example, but there are few limitations. As I have highlighted half-life, we don't know what is the half-life or how long this drug survive in stroma once we inject. It could be very less also. In addition to that, you can land up in complications like cataract. If you are injecting in the intracameral, then you can hit the lens and can cause cataract. One trick that you should do is never cross the pupillary area. Whenever you're injecting intracamerally, always stay above the iris. Don't go beyond that. Second is hyphema. If you hit iris accidentally, iritis, yes, those who have done it, they must have noted that very next day you get a lot of severe reaction. Corneal edema, if these drugs are toxic or if you inject too much and the concentration that you have prepared is not appropriate, then you can damage the corneal endothelium. New infection, as I said, if you repeat the when you are repeating intrastromal injection, if you are reusing the 30 gauge needle again and again, then you may create a new infection. AC reaction, especially with intracameral injections. The second common example of targeted drug delivery is endophthalmitis, where there is exudation in vitreous cavity. So you go in and inject the antibiotic exactly into the vitreous cavity. These are the different drugs. At RP center, commonly we use vancomycin and ceftazidime combination. So basically, when you are planning an intravitreal injection, remember informed consent is very important, which often people miss. And it can be done as an office procedure or in OR. But if you have a OR setup, then that is the best approach. Pre-op betadine cleaning is a must in all these cases, and surgeons recommend from 30 seconds to 5 minutes. You have to put betadine and wait before planning your injection. Always put a speculum, and the distance that all we know. If it is a aphakic patient, you can go 3 mm, pseudophakic 3.5, and if it is a phakic patient, you have to inject at 4 mm from the limbus. This is a short video how it is done. Basically, you earlier they used to use a 26 gauge needle. Now 27 as well as 30 gauge needle can be used. Once you inject, you can see the antibiotic going to vitreous cavity. While coming out, always use a betadine soaked cotton bud to press that area. Third third commonly used procedure is probably this supratarsal injection of Tricot for cases of giant papillary conjunctivitis, as you can see. But this figure is important. This is exactly where you should inject. This is your tarsal plate, and this is where the steroid need to be injected. This is again a short clip about that. But before injection, few surgeons they prefer cleaning this area with povidone iodine. But remember, you have to wash it. If you use a betadine cleaning of this papilla, as you will see in this video. So first clean it with betadine and then wash it off and then inject. You can see the cornea has already epitheliopathy because of this giant papillae. So take 0.1 to 0.2 ml of triamcinolone acetonide and inject in the area which I showed you in the figure. And don't try to inject the entire volume in one place because it's a very rigidly packed tissue. There is not enough space. So you have to repeat 3 or 4 times at multiple sites. Results are usually good, especially in cases of giant papillary conjunctivitis, but remember the effect lasts for only 3 to 4 months. So after that you may have to repeat it or you may continue with topical steroids. This is another example of targeted drug delivery, especially in cases of subretinal bleed, where a mixture of tissue plasminogen activator and Avastin and air is injected. You can see 3 ports have been made, and this is a special translocation needle which is 41 gauge. With that you can go in. See, this is the area of retinal bleed, subretinal bleed. With that needle you can go in and exactly inject at the site where it is required. So this is another form. So calogen, almost all of us have done this. You can inject intralesional triamcinolone acetonide into the lesion in 0.1 to 0.2 ml, 40 milligram per ml concentration. You can inject from subconjunctival side or from the skin side. It's always better to inject from subconjunctival side because it will avoid any scarring that could occur if you inject from the skin side. In addition to that, there are few indications which I haven't included here, like at RP center in capillary hemangioma, we are injecting steroids directly into the lesion, and there is a thesis going on. In fact, there is a thesis about injecting bleomycin, so that is probably another example of targeted drug delivery system. But remember, whenever you are planning a targeted drug delivery, especially in cases of keratitis or endophthalmitis, you have to back up your plan with your basic scientist, microbiology department as well as pharmacology department. Don't inject anything. Before concluding, I'll just give you one example. When I was the senior most SR, one of my colleagues, SR, what he was doing in a therapeutic PKP patient, the patient was for therapeutic PK posted, but tissue was not there, so he was injecting betadine into the anterior chamber. So you should never do this because you know betadine can knock off your endothelium, it can cause trabeculitis, it can cause fibrosis. So whatever targeted drug delivery you are planning, that has to be discussed with your basic scientist, or if you don't have that facility, you should go through the literature, do a thorough literature review, and then go for targeted drug delivery system. With this, I'll conclude my talk. Thank you for your kind attention.
Thank you very much, Dr. Praful. That was a beautifully rendered, detailed discussion of the various applications and with beautiful videos. I'm sure everybody enjoyed and also learnt a lot. So we have a few minutes for any comments. Dr. Shorya Azad is here, who's also a panelist in this session. Anything you would like to add or mention? Is there a hand mic for Dr. Shorya?
So one of the other indications of targeted drug delivery would be in a subretinal abscess. So we've also published the data in which in these subretinal abscesses the minimal inhibitory concentration of the drugs do not reach as we are just injecting into the vitreous. So in these cases we go to the subretinal abscess and we give it just like we gave in the subretinal bleed, just near the abscess, and then that works much better. Apart from that,
okay, thank you so much. That was very useful. So I'd like to thank the chairpersons and all the panelists and speakers for this session. And we can go ahead with the next session, for which I'd like to invite the chairperson, Dr. Jaspir Kaur, to please come, and we can have Dr. Shorya as well with Dr. Jaspir. So the first lecture, Dr. Jaspir will be giving the first lecture, Translational Ocular Biochemistry, Bench to Bedside. And Dr. Sana Nafis is available online. Just check because hers will be the next lecture. So will somebody confirm if she's there? Okay. So Dr. Jaspir will be, is the head of our ocular biochemistry. And the lecture is on Translational Ocular Biochemistry, Bench to Bedside. The beauty of these lectures is there's so much of clinical application, And the information, if you read it from any textbook or any journal, is very dry and difficult to assimilate and sort of relate to it. But I think this is very fantastic, the kind of knowledge you are getting today. Thank you.
Thank you, ma'am, for such a good introduction. And we know that biochemistry is there in RP Center since many years, more than 25 years, and I'm here from past 19 years. So basic science actually takes lot of time to study the biochemistry or the molecular pathways of different diseases. But to translate them into the clinical side, it comes a long way through. So we have spent in our department at least 10 to 12 years to study the basis of the ocular biochemistry. Now we are in a stage that we can translate them into the clinical side. So today I will be highlighting the research in ocular biochemistry that can be extended to the patient care. And I will try to use less basic sciences words so that it can be understood by the others also. So biochemistry does not only means blood investigations, it is much beyond this. It includes molecular biology, genomics, proteomics, and also it really gives us the development and progression of many diseases, the understanding of progression. So when we understand the progression and development of disease, then only we can innovate something. We can think of something new, what is missing. So that is the important thing which we thought, and we have studied many diseases at the depth, at the cellular level, to come at this level of today what we have achieved. So the knowledge which we gain from basic sciences is how we can extend to clinics or to the patient care. That is through translational research. The translational research is from the labs, whatever we have achieved can be converted into a clinical practice. But sometimes we observe or you get new things in the clinics, and we go back to the lab for the validation and scientific reason. That is reverse translation. But we are now at present focusing on the translational research, what we have achieved in our labs from past 15 years that we can extend to the clinics. So we are focusing on different ocular diseases. We are using different biological fluids. We are using tissue, blood, vitreous, aqueous, and tears. And of course different technology we are using it, both genomic and proteomics. Microarray we are outsourcing, but we are doing the basics of microarray here, and we are using RT-PCR. We are now in NGS also we have done, and multiplex ELISA is the main focus, because you can get I will be telling in my slides how can you utilize in the clinics for the diagnostic and the prognostic purposes. We have found many biochemical pathways involved in genesis and progression of diseases. We have identified and characterized some genetic protein markers with more than 3 to 4-fold variation, that is whether they are upregulated or downregulated at the cellular level. So it need not be like you can get high expression of some protein. Sometimes it's not presence of the protein also tells you the disease progression. So we have taken only those genetical markers which are shown 3 to more of a 5-fold increase or decrease of the levels. So through the microarray and NGS, we have identified those proteins for different ocular diseases. And now we are in a form how our research achievements can be translated to the patient care. We have mainly focused on 4 diseases like ROP, glaucoma, DR, and ocular tumors. I need not tell what is ROP to you, but definitely the question lies why only a subset of preterm infants develop ROP despite the same gestation age, exposure to the same environmental factors. And why some ROP in premature infants progress despite regress in timely intervention, and others it regress spontaneously. So these 2 questions were there because in clinics they are treating ROP, but they are finding that some of the ROPs only progress to more severe and other regress it spontaneously, and some preterm infants does not develop ROP. So these 2 questions we thought, like if we read the ROP, the disease progression and the disease development in proper way, then we can do it. So one of my PhD students worked wholly for 5 years on ROP to find out what are the molecular changes behind it. So we have worked ROP both at the genetical and at the circulating stem cell level. Through microRNA, we have found some candidate genes which are present in preterm infants who developed ROP and who does not develop ROP. We compared and also compared with the full-term babies. So we got a panel of genes. Out of 3 to 4-fold increase, we have selected some candidate genes. And circulating stem cell we have detected in the preterm infants who developed ROP after the birth of either 31 weeks or after the birth 4 weeks follow-up. And we found that EPC levels were very high in these patients, in these infants. So now we were focusing like whether the infants which we are following, we are doing this, we who have developed ROP, who has not developed ROP, whether we can identify the infants at the time of birth itself, whether they are going to develop ROP or they are at high risk of developing ROP. That question lies after this. So now we are focusing on microRNAs. So microRNAs, these are the small microRNAs which are circulating in our body. These are in the periphery blood. But now they are catching as a biomarker, and I want to mention that FDA also has approved use of FDA biomarkers in clinical settings. But in ROP we are trying it because microRNAs are stable. They are less affected by RNAs, that is the degradative enzymes in our body. They are stable with high pH, high temperature. And one microRNA regulate many pathways. So if we can identify microRNAs in circulating, that is in periphery blood of the preterm infants, that are correlating with the high risk of ROP development, then there will be a great achievement. So this we are going through because one project we finished with ICMR with the PhD, and now with the extension of that project through ICMR, we are proceeding towards the whether we can use this microRNA as a biomarker for identifying the preterm baby who are at high risk at the birth itself. So at the 0 day we take the blood and then follow the patients. We are also studying glaucoma at the genomic and the proteomic levels, and we are using blood, and we have done NGS. Through NGS we found some markers for mitochondrial DNA variations. These variations we can use it for real-time panel, we can make it and use it for the deduction, and we are also done the pedigree analysis for using this NGS. Through SRB we got some markers. We are getting some markers which are at POG and PSCG level, both glaucoma, that these genes are present at a very high level or not present in these diseases. So we have made at least 10 panels of RT-PCR genes. Now we are screening on larger number of samples in this project, so that through DST we can translate them into the kits. That is real-time PCR based kits we are preparing. So through one project which we have spent at least 5 years of our time span, using that data, we are now proceeded to second project where we can using this real-time PCR genes which are differentially expressed at different level, so that a diagnostic kit can be prepared at the blood itself. So we can use in high risk population, glaucoma at high risk population, before they get onset for the clinical onset. So that is a great achievement if we get through this diagnostic kits on a larger population. So second phase we are facing to do on a larger population. And one of our student does proteomics and aqueous humor with it through ICGB, and we got some panel of proteins that are differentially expressed, and we are proceeding with ICGB to how to proceed further to use this, because it's through understanding like how can we translate them into the clinical side. Now if coming to DR we know that it's through diabetes, but why only subset of diabetic patient develops DR? Despite that a short duration of diabetes, whereas others does not develop DR in face of long-term standing diabetes. So that question was in our mind. Secondly, we observed that some diabetic patients develop DR in spite of excellent glycemic index control, and regardless elevated HbA1c, some diabetic patient does not develop DR. We know that we relate the diabetes with genetics, but I think it's beyond genetics. Something else factors are playing role, because in non-genetic patient also diabetes develops, and that progress very fast to DR, then from NPDR to PDR. So progression is also at very high speed. So it means some other unknown factors apart from the known pathways in diabetes, some are playing role. So these questions made us to think, and we have done Genetic analysis, again using microRNA, because you can do in the periphery blood itself. Through microRNA, we have got some miRNA 18A, 18B, some we have identified markers which are present in DR but not present in non-DR patients. Both are diabetic but they are not present. And some microRNAs we have observed that the patients who progress very fast from NPDR to PDR, these microRNAs are present. This is again through an ICMR project. We are again working on a larger scale because they need a larger sample size that they decide, ICMR decide. Our statistical decides that you can do a process project on this many samples. But when we extrapolate to translational research, they need that how much samples to be need. That is decided by the funding agency or through which you have to translate our research. So we have also got some microRNAs, like this is an ongoing project. But as I said, there are some other factors beyond this genetical factor that is playing role. So we thought whether we should study gene environmental interaction. So we have environmental, we have lifestyle, we have different environmental, we have air pollutants which are playing a major role. So to study this, we thought that maybe whatever in our mind we had, that only why a subset of groups are converting into diabetic to DR and from DR to more severe DR, or why others are silent. So we thought only studying the diabetes and diabetic pathways are well known. You can read in the literature, you can see the molecular pathways, but something else is also there. So it may be the environmental factor that are playing a role. So in a collaborated research project we are proceeding, we are taking the adipose tissues, because whenever the air pollutants are there, that gets accumulated in the adipose tissues. So adipose tissues is the best one to study. So whether air pollutants are actually playing a role or some other factors are there in these diabetic patients. So this is a collaborated work from different departments and different institutes. So we are focusing on adipose tissues to see what are these adipose tissues accumulations are there. Of course, these are diabetic patients undergoing surgery, and non-diabetic patients also. So we are comparing and find out whether this some new pathways comes, or what are the concentration of this air pollutants in these adipose tissues. This is a multicentric and multidisciplinary work, and we are focusing to DR, so that whether a subgroup which we are thinking that why these diabetic patients, in spite of having a optimal therapy for diabetes, are still not under control glycemic index. So they have taken metformin, insulin, but still the glycemic index is not under control. So it means some adjuvant therapy, some other pathways is disturbed in these patients, which we are not focusing. We are just focusing on the pathway we know that diabetes causes. So we are giving the treatment according to that. But what are the other pathways that are disrupted? So some adjuvant therapy is required. So maybe the side effects of metformin and other insulin can be reduced, the dose can be reduced, but you have to add some other molecules adjuvant to this in these patients to control diabetes. That is the objective for this project. So previously we also worked on ocular tumors, uveal melanoma and retinoblastoma. Uveal melanoma we have studied through microanalysis, and we have found some candidate genes in that, and that can be used in future for diagnostic and prognostic and therapeutic targets. But of course on retinoblastoma we are focusing now more. We have previously done our work on blood and tissues, and in blood we found some EPC cells which are higher in RB as compared to non-RB, and tissue through microRNA. This was DPT funded project, which we got some microRNAs genes. Then we have translated to protein, and these proteins we found that these are differentially expressed in retinoblastoma genes, retinoblastoma patients as compared to normal. But at present, what is this when we take the biopsy, the limitation is that it has the risk of spreading to extraocular site when we take a biopsy. So we thought better to go cell-free DNA. These cell-free DNAs are, what are these? These are this originates from the cancer cells, and it comes to the blood or fluids. So in RB, if we take the aqueous humor and try to do the aqueous liquid biopsy, and then correlate with the disease diagnosis and prognosis. If we take aqueous, we are in a position to take several serial collections during the disease progression also. We need not take solid biopsy every time. And second is that cell-free DNA is quite stable. And this has been done in many other cancers, but not in RB. So I think this is the first project from ICMR. We have got it in RP center, and maybe to my best of knowledge, this is first in India itself, to try liquid biopsy with the help of oncology department in RP center under guidance of madam also, to try for the liquid biopsy and correlate this cell-free DNA. So we are doing the cell-free DNA. We are trying to study the microRNAs in cell-free DNAs in this. So we'll do the cell-free DNAs and then correlate with the disease progression and diagnosis. This will be a great achievement. This is just started project from past 4 to 5 months, and we are in a state that we are correlating. First we thought we'll do with the Northeast, but due to COVID we could not get the permission from ICMR. So they said to do in the one site, one center itself, RPC. So they have recommended to do first, then extra do it. So we are just doing in our center, it's with Dr. Bhavna, Dr. Lomi, and under guidance of ma'am. So we are trying to do this cell-free DNA analysis. Now comes the tears. Tears are catching eyes for everybody, like, because it's non-invasive mode of sample collection, is readily available, close to the site, and of course it represents many eye diseases. But the question is that we get very small amount of tears. So we have to optimize our technology. Where we have a sample limitation and we can get lot of information, then it means we have to standardize our technology, our mode of study. So what is this? Like simple ELISA if you do. For a known biomarker, ELISA you can do because if you know one marker, you have to study IL6,
Dr. Jaspreet,
IL.
we have Dr. Sana also online.
Yes,
do you have a lot of more slides or
No,
just?
ma'am, just
okay, thanks.
So if we have ELISA, then we can do simple ELISA if you have a known marker. You know that this inflammatory marker may be associated with that. So you want to try in your patients, you can go. But for tears, we have only 5 or 10 microliters. So we thought, whether using this 5 to 10, can we use multiplex ELISA? So in multiplex ELISA, you can identify many proteins in same sample. So, but the thing is, you should know what proteins you have to study, what markers you have to study together in just 5 or 10 microliter of your tears. But you have to design it. You have to panelize and make the ELISA kit. So that we have done in our department. Like, depending upon which disease we want to study, which parameters we want to study, using such small tears sample, 5 to 10 microliter, you can study. Of course, the best way is to do LCMS, but we don't have facility at RP center right now. We have to go to ICGB and other things for this tears samples analysis, and you can identify novel markers in that. But it's quite costly also, and it's not like, if you have to find out some novel markers, then it is the best ideal way to proceed. So these are some markers in different diseases we have identified, and simply like MMPs, if you want to study 9, 10, so some single markers you can study by ELISA, but if you have to do multiplexing, you can see with the paneling out and designing your things. So if we say that different cytokines, chemokines you can study in a single reaction, it's time saving, and this is a particularly very effective, I should say, diagnostic tool, the multiplexing for small amount of, because we know that in ophthalmology we have a limitation of samples, the quantity. So small quantity you can use it, and I would like to mention that you can in literature or in you can have 65 parameters together, you can study in multiplexing, but in our lab till now we have studied only 24 parameters together in one multiplex. We have designed with the help of a Pune company that we have used 24 panels, 24 different biomarkers in a single sample. Now, in nutshell, I will say that outcome of
You
any
wind
basic
up, Jaspreet, please.
Yes, sir. In outcome, I want to say that basic research outcomes only comes when we have a good support from the clinicians and other researcher, basic sciences researchers. So we have to work together. We have to gain the knowledge from the clinicians, clinical side, because we don't understand the clinical part of that so well. And basic research can be done if we can sit together, we can discuss, and we can make an effort, and it can be translated to the things. I would like to acknowledge my team, is Dr. Sana, Dr. Swati, Dr. Bhavna, Dr. Suraj, who has all worked for this, for making the basic science or basic biochemistry itself from what I have done from 15 years from this to this point. Thank you, ma'am.
Thank you so much, Dr. Jaspreet. Please join on the dais as chairman. And that was very nice to have an overview of the entire range of knowledge that one can get by biochemistry and the analysis. 2-3 points just for the residents. One was that you mentioned the tissues and the blood and the aqueous and the tears. So these samples, if supposing the clinician suddenly decides in the OT, for example, there's some unusual cataract and they decide to send the aqueous or the lens, material. So any guidelines as to how it should be sent? Is there, can they just send it in saline or a small, because as you said, the quantity is very less. So what containers should they keep ready in the OT so that they don't have to run to the lab and ask for it? So just a few things as to how these specimens, the blood, the tissue, the aqueous, the tears, just give a little bit of guidance.
If we have to study the DNA, then you can give the blood in the room temperature itself. There is no issue. But when you have to do protein, like multiplexing, or you have to do the protein markers, it's best way to put it in a chiller, minus it. We have a portable chillers, or either in the OT also you can buy, and you can keep in that. We need in the chillers. So the temperature in the protein markers is very important.
Sample tube, because supposing it's just 0.1 or 0.2 ml, hardly oil, should they just send it in the syringe? Because sometimes they will use a 1 ml syringe and they may be barely 0.1 ml. So how should they, so that they don't lose that precious specimen?
Okay, the thing is we have Pcr tubes. This is very small tubes. You can keep it, and the chillers has the fitting into this. But if you don't have that also, you can give in the syringe itself. But you have to keep it minus 80. You have to keep it in the chiller, the syringe also. We can transfer our thing in our department, but better to keep the PCR tubes, this 0.5 ml tubes in the OT, and some chillers, so that whenever you get the sample, put it in immediately and store it.
Thank you. That's very helpful. So we now go to another very important and a very fascinating aspect. A big round of applause for Dr. Jaspreet. And we go ahead with the next lecture on human cell culture and its applications by Dr. Sana Nafis.
A very good morning to all of you. It is an honor and privilege for me to present here, and the topic of my presentation is human cell culture and its application. Now, what is cell culture? Cell culture is the process by which cells are grown under controlled conditions like temperature, pH, CO2 and oxygen. It is an indispensable tool for basic research and a wide range of in vitro studies. Cell culture systems develop to mimic the physiological environment in vitro. Cell cultures can be applied in different branches like biochemical research, cancer research, virology and some other branches. If we see in biochemical research, cell culture are used for knowing the mechanistic pathways in different diseases. It can also applied in metabolic and aging studies. In cancer research, cell culture is helpful for knowing the mechanism of cancer and screening of chemotherapeutic drugs. In virology, the application of cell culture is used to know the replication and growth, development of viruses, to know the mode of the infection. And in some other branches, we can apply the cell culture to know the cytotoxicity of drugs and to screen the drugs for different pharmacological actions. And And cell culture can also applied to know the genetically engineered proteins, hormones, and antibodies. Now, what are the advantages of cell culture? It provides a starting point for researchers to gather insights into how a cell responds under a controlled and isolated environment. These models provide a low-cost study platforms. They are ideal when there is a specific dynamic effect or end-to-end points. This is especially valuable for complex tissues such as pancreas, which is composed of various cell types, where in vivo examination of individual cell is not possible, so we study cell culture in these type of studies. Now, basically human cell cultures are of two types, primary cell culture and established cell culture. Primary cell culture are those cell cultures that are derived directly from the patients, and their expansion and cell division ceases after a certain period of time and their senescence occur. Whereas established cell lines are permanently established cell lines that will proliferate indefinitely. And there is another stem cell culture. It is also a type of a primary cell culture. They have differentiate into various cell types depending upon their signals. Now, how to maintain the cell culture? We are maintaining cell culture in our lab, like we are acquiring tissues or cells directly from the patients or from individuals. Then these cells are mechanically or enzymatically dissociated and transferred into the media, and now these transformed into continuous or finite cell lines. Now these cells are preserved in different media according to their study protocols, and these media should be changed after a certain period of time to maintain their viability. Now we have a 2D cell culture and a 3D cell culture. Conventionally, the 2D cell culture poorly mimic the environmental condition, and they may compromise the reliability and significance of the data. 2D monolayer cell culture 2D monolayer cell cultures are cultured on a rigid and flat surface. However, it has some limitations. Like in drug discovery phase, many of the drug fails during clinical trials as their data is not up to that limit because of their unnatural environment. So to overcome these issues, we are using a 3D culture. 3D cultures are spheroid cultures that are considered to be improved cell culture models, and they deliver a high physiological environment for preclinical discovery, especially in cancer and stem cell research. Now, it is a pictorial representation of 2D cell culture and the 3D cell culture. In 2D cell culture, cells lie on a flat surface, whereas in 3D cell culture, they are on a extracellular matrix, which is a spheroid shape, and give a 3D structure. As the natural extracellular matrix is important in survival, proliferation, and differentiation, and migration of cells, different hydrogel cultures that form the 3D structure are used to make the 3D cell culture models. Now 3D cell cultures are basically of two types, static and dynamic, and 3D is made with and without biomaterials. Biomaterials used to make these 3D cell cultures may be hydrogels or the microcapsules. This is a representation of 3D cell culture in which cells are grown over scaffold. In this, the confocal imaging is used to quantify the cells, whereas fluorescent microscopy is used to qualitative cell analysis, and for cell morphology, same technique like scanning electron microscope is used. Now, what is the difference between 2D cell culture and 3D cell culture? 2D cell culture has lower cell density and have altered cell morphology, whereas 3D cell culture has higher cell density and yield high physiological environment, and they are especially suitable for tissue engineering and therapeutic applications as they give a natural environment. Now we are working on a glaucoma cell culture model in our lab. As we all know that in glaucoma there are two main sites that are affected. One is trabecular meshwork and other is retinal ganglionic cells. Now we are working on some unknown pathways that may be involved in glaucoma, and another we are studying on we have a caudal formulation, and it is used to therapeutically target the glaucoma. We have some high environment cell culture dishes, and we are making this glaucoma cell culture model in vitro by increasing the temperature in a petri dish. This is a picture from our department. Like we are growing TM cell cultures. We are acquiring these cultures directly from the glaucoma patients, and we are culturing in our lab. And second picture gives it is a cell line, retinal ganglion cell lines that we are working on in our lab. Now, in a nutshell, human cell culture gives us same origin, and it gives a natural environment. It is a basic model to study different targets or to therapeutic targets, and especially 3D mimics the same conditions. Thank you.
Thank you so much, Dr. Sanna. That was a very nice explanation about this very important and cutting edge aspect. And real credit goes to the department that you have remained ahead of the curve and also made sure that all these facilities are available. It takes a lot of effort to get all the regulations in place and also to make all the arrangements. And it requires a very high level of expertise to maintain these cell cultures. Thank you so much. I would like to invite Dr. Shorya Azad to give the next lecture on the role of inflammatory mediators in vitreous in diabetic retinopathy. This is another very important aspect, and it is another example of how close interaction, as Dr. Jaspir said, and close sort of communication between clinicians and basic scientists can be very helpful for both of them.
Thank you, ma'am. So, a very good morning to all of you. So, I'll be speaking on the role of inflammatory mediators in diabetic retinopathy. So, basically during the course of the talk, we will be having these keywords: diabetic retinopathy, inflammation, and vitreous. So first we will be discussing a bit about diabetic retinopathy and its pathogenesis, how inflammation is involved in the pathogenesis, and how these inflammatory mediators inside the vitreous cavity affect the vitreous cavity and bring long-term changes in the vitreous cavity, which is called the diabetic vitropathy. So in a nutshell, we already know that diabetic retinopathy is the most common microvascular complication, and the only means of actually seeing disease progression is glycemic control. And even as ma'am said, after a good glycemic control, we have patients progressing to advanced stages. So why this happens? As ma'am was touching upon points of genetic and environmental factors, well, diabetes in itself is a multifactorial and has multiple pathways in its pathogenesis. And by just focusing on one pathway, we probably might not be able to tackle the disease. And thus, we have, once the glucose increase in the blood, it gets shunted through different pathways, which leads to upregulation of basically two cascades. One is the vascular cascade and the other one is the inflammatory cascade, and then there are cross interactions between both of these. So as you can see, when we assess for diabetes, we have a basic knowledge in our mind that it is a vascular pathology. We seldom think it as a neurovascular unit that is there. So basically the vascular bed which is getting affected is then affecting the neuron, and this neuron is then releasing some factors which leads to the whole cascade of events. So as we know that, as I talked, the various biochemical markers which are there then leads to loss of pericytes, which is the first initial effect that happens in the vessels, and it leads to basically formation of microorganisms that may lead to hemorrhages or maybe retinal edema. And apart from that, there's also endothelial damage, which leads to endothelial thickening, and that leads to an ischemia, and this ischemia will then lead to neuronal injury. Now this injury that happens is basically what then releases cytokines, which starts the inflammatory cascade. So what we should understand over here is that the neuronal injury that is occurring is basically the precursor to the inflammatory cascade, and then there are cross interactions always there in between the cascades. So as we can see over here that we basically have either two ways of looking at the disease progression. One is by assessing the glycemic control through the systemic compartment, that is the blood sample, and the other is by looking into the eye and looking for fundus findings. Now fundus findings may not be actually visible in a patient who is having diabetes but having no diabetic retinopathy, and this stage glycemic control is the only way we can find out about the pathological process. However, studies have recently shown that some of these inflammatory mediators are also raised in the systemic compartment, and this shows that these are signs of initial neuronal injury that is occurring in diabetic retinopathy. And this is also evidenced indirectly by the functional and anatomical changes which lead to neuronal dysfunction in preclinical stages. These have been documented on ERG, microperimetry, delayed dark adaptation, contrast and decreased contrast and color vision, and different layers on OCT and OCTA. Now, some of these studies have also been done at our center. So, up till now what we have understood is basically that the neuronal injury is leading to the inflammatory cascade, and this inflammatory cascade is then leading to inflammatory mediators in the systemic compartment, that is the blood. However, we do not know how it affects the local microenvironment, that being the retina. So, here is where vitreous humor is important, and vitreous humor, although is a gel-like avascular structure in itself, it does have a close proximity to the retinal vessels, and these retinal vessels can then leak cells into the vitreous, and the vitreous then acts as a depot or a reservoir of these mediators, upon which we can then study this and see for which inflammatory mediators are upregulated, downregulated, and these are called biomarkers. So, recently there have been enough evidence of how inflammation is involved in diabetes, and also more so in the diabetic retinopathy. So, many studies have been done in DME as well as PDR, and they have shown that both circulating biomarkers as well as the local biomarkers either in the aqueous or the vitreous are raised, and these are raised in comparison to age matched controls in both DME and PDR. Even while assessing stages of DR in patients who are having no DR, in patients who are having PDR have more incremental increasing in these mediators in comparison to no DR. And this is another study which was done over here as a part of thesis, in where we compared the plasma and vitreous biomarkers both in type 1 and type 2, and we also correlated to glycemic control. So, all the markers were significantly elevated both in type 1 type 2 when compared to the controls, but when we correlated to HbA1c levels, it was seen that in type 1 diabetics, mainly the VEGF or the vascular cascade is the more upregulated, whereas in type 2 diabetes, it is VEGF along with other inflammatory markers and also the RAS pathway, and thus telling us about that there are other pathways which might be involved and having an effect. So, once we have established that inflammatory markers are present in the vitreous, what do they do? So, basically we have known that injury releases cytokines, it is there in the retinal interstitium, then it goes to the vitreoretinal interface and then finds its way in the vitreous. Now, vitreous has these liquid pockets where they get concentrated and then have a depot sort of an effect, and because the vitreous have a prolonged turnover and remodeling of vitreous, there is decreased clearing of these cytokines, and that is why the reason why they have increased duration and more potency as well. And at times the increase in these inflammatory mediators acts as a chemoattractant for the retinal neovascularization to grow from the internal limiting membrane to the cortical vitreous, and they grow from there. And that is the reason why it has been thought that if PVD occurs in such patients, it is protective, because then it leads to abortion of these new vessels, as well as in patients who have undergone vitrectomy do not show as much proliferation as ones who have not. So, what are the clinical aspects? So, how does it change the vitreous? So, the rise in these inflammatory markers in the vitreous must be having some effect on the vitreous structure itself. So, what it leads to is liquefaction of the central vitreous. It may lead to an early PVD, which is often incomplete because these new vessels which are sprouting from the retina have strong additions to the vitreous, and these may then lead to complications, as I will discuss in the further slides. It also leads to, due to in diabetes there is a lot of cross-linking that is happening at the collagen level, and due to which there is formation of sheets. So, in a vitreous cavity which might just have a hyalod that is there outside and a vitreous body which is there inside, there will still be many sheets inside the vitreous, which is called vitroschisis, and which may then affect and cause other complications, which again I will discuss in the other slides. So, apart from this, because of the raised inflammatory markers, there is some amount of vitreous proliferation that is occurring, and these lead to the membranes that you see, the ones which lead to the traction. And apart from that, you also have thickened ileum. Sometimes the ileum is almost 2 times as thick as in a normal age match control. So all these changes, as I said, so as you can see over here, the first one, there is PVD starts early in such cases, and there is central degeneration of the vitreous and liquefaction, because of which there is collapse. And as you can see, the sprouting of the vessels that are there, the red vessel, and that is sprouting inside the vitreous, cortical vitreous, which then gets some bands then develop because of proliferation of the cells, because of inflammatory mediators, and that may lead to a vitreous hemorrhage in the future. And there is vitroschisis, as I said, and also partial PVDs. So what do they lead to? Clinically, what did happen? So these changes in the vitreous, either if it's a persistent focal adhesion, it will lead to a vitreous hemorrhage, because it is just putting traction over the vessel, and the vessel might rupture and lead to vitreous hemorrhage. Or if it is a broad sort of attachment, then it will lead to a tabletop RDs, as you see. Apart from that, it is also seen in patients with DME and VMTs. The traction over the macula will occur because of the thickened ileum, as well as the proliferating cells over the ileum. And in cases where you have the vitroschisis and multiple preretinal membranes, it might also lead to a ERM. Apart from just the vitropathy that it causes, it does not just cause the vitropathy. The inflammatory mediators also do bring changes in the retina itself. So there's increase in the microaneurysms, increase in the macular edema, the ischemia leading on to the new vessels elsewhere, and the NVD, and also tractional detachments in the future. So what therapeutic interventions do we have? So the problem over here happens is that there are two basic pathways. One is the inflammatory pathway and one is the vascular pathway, and both of them has lot of overlap and interaction. So it's difficult to actually say the cause and the effect, that which one is actually causing which manifestation. So it's difficult, and there are many inflammatory mediators. So we do not know whether we should progress with a wider approach in which we give an anti-inflammatories, or a narrower approach in which we basically focus on specific markers. So the best would be somewhere in between to go with a tailored approach. Like in the case of DME, I probably know IL-6 and IL-8 will be upregulated, to basically an inhibitor of IL-6 and IL-8. Or maybe if we get to know through the vitreous which local inflammatory mediators are upregulated, then we can probably target those. So to summarize, basically we know that the neuronal injury is what starts the inflammatory cascade, and it sets in early in diabetic retinopathy. And the raised inflammatory mediators can be seen both systemically and locally. Local inflammation then leads to changes in the vitreoretinal interface and diabetic vitropathy, and it leads to early but incomplete PVD, which leads to many complications of diabetic retinopathy like TRDs, vitreous hemorrhage. And these mediators, because there are so many, it's difficult to actually go with either a broad or a narrow approach. So further, in future, we need further explanation with the tailored approach, which is probably the way to go. Thank you.
Thank you so much, Dr. Shorya. That was very nicely put, and it has also shown how there's so much of complex interaction going on. Just had a little question, that are we sure that it is a neuronal injury which is leading to it, or could it be that from the vascular supply there are the inflammatory mediators coming which are leading to the neuronal injury and then leading on to... Is that a possibility as well?
Because it's so complex and there is so much of overlap between, it's difficult to actually identify whether that is the cause. But yes, because of the vascular compromise that we have, it leads to the neuronal injury, and that is what starts the inflammatory cascade. So that is how it is.
And I think that's very important, as you emphasize, that the control of the diabetes also has a role to play. So some modifiable factors may reverse if they, even though they've reached this end stage, they might be able to improve. So the control of diabetes is also very important in such cases. Thanks a lot. So I'll request Dr. Rohan Chawla, who's also a panelist in this session, to please come forward and give any comments, and then we can take questions. We have a few minutes for questions. For both the sessions, we can take questions together. So Dr. Rohan, if you would like to make any comments.
Thank you very much, ma'am. Very nice lecture, Shorya. So like Shorya has pointed out, it's a very complex disease. And like ma'am said, whether the neuronal injury occurs first or the vascular injury occurs first, so basic problem does start with the vascular issue, because it is diabetes, the hyperglycemia, the formation of ACE products. All that leads to an abnormal basement membranes, which leads to leaky membranes, avascular areas. It starts from there, but then when the neurons get affected and they get affected by the ischemia, then a second process starts there, that they also start releasing other factors which complicate the entire process. And the neurons do get involved very early. So that is why it's a mixture of both. And if at any stage, if we can pinpoint a biomarker or agent which can be targeted, then probably the therapy would be better. And one thing I think is not mentioned, recently angiopoietin inhibitors have been started using in combination with anti-VEGF. Right. So a combination of anti-angiopoietin and anti-VEGF inhibitor is available in the market now. Maybe soon in India also it will be available. So that has also been shown to have good effect.
Thank you so much, Dr. Rohan. So I'd like to thank the chairpersons and all the speakers and all the panelists for the first two sessions. Are there any questions anybody would have, or should we go ahead with the next one? Okay, so I'd like to request the chairpersons, Dr. Pandyan and Dr. Seema Kashyap and Seema Sen, to please come forward for the next section. I had to just go for some work, so I've requested Dr. Pandyan to be here, and Dr. Seema Sen, please, to take over. Dr. Seema Sen is the head of Ocular Pathology. I'd request you to please come, ma'am.
Thank you, Dr. Radhika. So after the first two sessions, now we move on to ocular pathology, which is my department. And we asked the clinician, Dr. Rachna Meel, to give her experience about how the management of the patients changes after our pathology report.
Thank you, ma'am. Yeah, so at the onset, I am extremely happy to be part of this workshop of Allied Lab Sciences that is being conducted for the first time, and it's my pleasure to be here and a part of it. And I have a very interesting topic that I'll be talking about: how to correlate histopathology findings with tumor, pre and post-treatment. So if you've done any oculoplastic surgery, or for that matter a small oncology procedure, I'm sure you're familiar with that experience of, you know, big achievement when you get a report which is exactly in line with whatever you thought of. All right, and you are like, yes, this is what I thought of and this is what the pathology report says, right? On the other hand, sometimes you get a report which was not there in your mind when you first sent a specimen after an excision. I'm sure many of you would have excised cyst of mole, right? But imagine you've sent it for a pathology examination and the report comes back and it says BCC. And you're wondering what went wrong with your clinical assessment, and you go back and look at your records and you think and you analyze and you see the clues that you've missed. And on the other hand, if there's a callation, again, you've excised it and you've sent it for a histopathology, which I'm sure you must do. And I know most of you know that if you have a recurrent callation in an old patient and you do an excision, you have to send it for a histopathology. And it turns out to be a sebaceous gland carcinoma. So have you missed out on something? So it's a teamwork. When you're doing oculoplastic surgery or oncology for that matter, it's a teamwork. The surgeon is working in a team which comprises of so many specialities, but I think the most important ones would be the surgeon himself and the pathology team. So it is their coordinated effort which results into a treatment outcome which is optimal in each case. So I'm not going to be talking about case scenarios where you've thought of something and you get something on histopathology and, you know, going on a case-to-case basis. No, I'm talking about how, as a surgeon, you can optimally use the pathology expertise to bring about optimal treatment outcomes for your patient. All right, whether it is in terms of treatment itself, prognostication, or further therapy after you've done your job. So that is what I'm going to be covering here. So as a surgeon, when you're planning to do a procedure, there are some must-knows for the surgeon, which you must know before you plan to send a biopsy specimen to your pathologist. For instance, if you're planning to do an incision biopsy. Now the sample size, of course, has to be adequate, but often you're taking a sample from an area which is very difficult to access. So I'm sure you cannot get a large enough sample size or an incision, on an incision biopsy from the apex here, or say if you have to get it from an extraocular muscle, which is such an important tissue and you don't want to damage it by taking a large biopsy. So your biopsy has to be small. So what do? So you communicate with your pathology team. You let them know what is it that you're thinking about, what are your differentials. They will think of what all that they have to do, the IHCs that they have to put off, whether they have to do any electron microscopy, and that decides on exact panel that they want to put on that specimen. So communication is very important, otherwise your effort will go wasted. That tiny tissue which is so important to reach on your diagnosis will go wasted. So that is an important aspect for a surgeon. The other thing when you're doing a biopsy again is to decide where you're going to take the specimen from. So if you open a sample and you find a necrosis, that is not the area that you're going to biopsy. What you need to biopsy is an area which is rich in cells and tissue architecture. So you avoid areas of necrosis and take it from an area which will give you enough sample for getting the diagnosis. And of course, as surgeons, you must remember excessive use of cautery has to be avoided, and also avoid the use of scissor when you're harvesting the biopsy specimen. It will only lead to crush artifacts, which will make it difficult for the pathologist to comment on the biopsy sample. Coming on to intraocular tumors, a lot of you may come across intraocular tumors where you may go in for enucleation, as it's an easy procedure which you can do. But as a surgeon, again, what must you know and how will you coordinate with your pathology team in order to be sure that you treat that tumor in that eye, in that patient correctly? You need to know that there are described clinical features which predict histopathological high-risk features for metastasis. We've published those, and these will essentially be older age, longer lag period, high FEMA, presence of serohypopion, stiff myeloma. So keep your eyes open. Not all group E eyes will have high-risk histology, but there are clinical features which if you see, you must communicate with your pathology team to look for them more seriously and do a more extensive examination to look for same. Sorry. Then of course, once you've enucleated the eye, you can yourself look for areas of suspicious extraocular invasion, which can be in the form of dilated emissary veins, which you can see in the globe itself, which you've enucleated. You must also palpate the optic nerve to look for any thickening, which could also indicate an extraocular extension. And of course, you communicate with your pathology team for the same. Melanoma. Melanoma is one tumor where prognosis has come a long way. There are ways to prognosticate with genetic evaluation on the tumor tissue. So if you have that facility in your laboratory, you have to know that you need fresh tissue for the same, and you have to make sure that it is available to your lab so that they could run molecular analysis on the same. Ocular surface tumors, of course, another tumor which is very difficult to treat because of the recurrences. And what are the recurrences because of? the edge recurrences. Your tumor margins are maybe positive on resection. How do you make sure that they are taken care of? So again, you subject them to appropriate pathology examination. You should know what to expect from your pathologist. If you do not send them the sample correctly, they cannot tell you whether the edges are involved or not. So you have to send the sample on an nitrocellulose paper. You have to make sure that you've aligned it correctly so that they know which part is superior, which is inferior, which is medial edge, which is lateral edge, and they can do the sampling of the same and give you a thorough report, and that can decide on adjuvant treatment in that particular patient. Of course, eyelid tumors. Again, if you're planning a frozen section, you have to know how you have to send your margins of excision, how they have to be labeled and oriented, and how long or short they have to be depending on the presence of instruments and the machines in your laboratory, in your pathology laboratory. So you have to know how your pathologist works, right? And again, if it is a sebaceous gland carcinoma, you have to keep your eyes open for pegytoid spread. You have to clinically evaluate for same and decide whether you want to do a map biopsy in the same setting or not. Exaggeration specimens, again, they can be very large specimens. Your tumor may be limited to just a part of the orbit. It's always good to talk to your team to let them know which is the source of the tumor exactly within the orbit and which are the particular margins that you're interested in to find out whether the surgical margins are involved or not. And then you can expect a report that you can rely on to decide for adjuvant treatment. Now that is not where the role of the pathology or pathologist finishes once you have the diagnosis. Is that all you want? If your report on inner retinoblastoma patient just says diagnosis retinoblastoma, that is not sufficient, but you need to know what all you need to find out in order to decide further treatment in that patient. So the pathologist not only gives you and confirms your clinical suspicion, he also helps you guide further management in particular case scenario. And with more and more targeted treatment and molecular therapy that's coming in, they also have a great role in deciding management in such areas. Again, like I was saying in retinoblastoma, you've enucleated an eye, you've sent it for histopathological evaluation, you get a report which says retinoblastoma. It is insufficient. So that's why you need to know what all you need to know within that pathology specimen to guide you in further management. So what is it you are looking for? You're looking for high-risk histopathology features. And what are those? Again, anterior chamber invasion by the tumor, a massive choroidal invasion, scleral invasion, or a post-laminar optic nerve invasion. So you can see here, this is the choroid which is completely engulfed by the tumor tissue. And this is again the optic nerve section where there's a retrolaminar invasion by tumor cells. Now these are the cases where you would want to go ahead with adjuvant chemotherapy. And it has been proven in studies that if you do not do so, 24% of them will go on and manifest systemic metastasis. So this makes all the difference to your management. Again, presence of microscopic residual disease. If there's extrascleral invasion or optic nerve cut end invasion, it changes the disease stage. You not only have to give chemotherapy, in addition, you also have to give external beam radiotherapy to the orbit. And it completely changes the prognosis in that particular patient. Coming on to choroidal melanoma. So this is one tumor where the prognostication has seen new horizons in the current era. We have now molecular markers which can tell you whether the case has a good prognosis or a poor prognosis. They have been termed as class 1 and class 2 based on the presence of particular genetic mutations, and class 2 has a significantly poorer survival prognosis. So you can tell your melanoma patient what he can expect over the next 5 years. And this is already making changes to the clinical practice. So there is this paper recently which analyzed the change in the current clinical practice for uveal melanoma management in the current era of molecular tumor analysis. What they found in this survey is that people who are conducting the molecular analysis routinely are now subjecting patients with low metastatic risk, that is class 1, with less frequent and intensive clinical visits, which is almost 6 to 12 months, whereas in patients with high metastatic risk, the surveillance is more tighter. It's done every 3 to 6 months and more invasive, and they're considered for adjuvant treatment early on. Eyelid tumors, again, I did mention in sebaceous gland carcinoma, one of the most lethal eyelid tumors, you have to look for pegytoid spread, but you may not have any clinical evidence when you're examining the patient or seeing the conjunctiva. But the tumor mass that you have sent, if your pathologist reports that it has a pegytoid spread, you have to look more closely. You have to follow up the patient more closely. Such patients with pegytoid spread are more likely to have a recurrence early on than patients who do not have pegytoid spread. So it's something that you should be looking for in your pathology report to decide on how you're going to follow up your patient. You cannot have a blanket follow-up for all your patients with sebaceous gland carcinoma. Again, look for perineuritic spread. If it is present, you may consider early on adjuvant treatment. It is in fact considered as an indication for adjuvant treatment in sebaceous gland carcinoma patient. So those are certain case scenarios where how pathology will change your management after you have dealt with the tumor itself surgically. Another very interesting scenario is of orbital inflammatory lesions. There can be n number of reasons for orbital inflammatory pathologies. You've done your lab work, you've done a systemic evaluation, you've done the rheumatology workup for the patient. You cannot find a reason for the orbital inflammation. That's when you go in for biopsy. And your pathologist actually tells you what is it that you're seeing, whether it is lymphoproliferative lesion, whether it is idiopathic inflammation, or more recently what is being talked about, IgG4 related orbital disease. So they are the ones who will tell you what it is, but you must also know about diseases that have been recently found and for which IHC can be done. Often a non-specific inflammation could just be IgG4 related orbital disease. But if you know, and if you ask, and if you communicate, you may catch that diagnosis, which is more likely to have more recurrences and a longer treatment. So to conclude, that's my last slide. So to conclude, it's very important to have a good communication and knowledge about what you want from your pathology team pre-operatively, and again, post-operatively, for you to have a knowledge of molecular studies that are going on and the advances that are happening, and then the team works together to give an optimal management outcome to each and every patient that comes to you. Thank you so much. Thank you, ma'am.
Thank you, Dr. Rachna, for giving your insight into oculoplasty and ocular oncology. And I really do hope we improve our communication, because that is the only way forward. And now, like she very rightly said, now it is beyond light microscopy. It's not just the diagnosis, retinoblastoma or melanoma. We have to move on with molecular markers, and this is going to help the patients with targeted therapy.
Yes.
Thank you very much.
Absolutely, ma'am. Thank you so much, ma'am.
Are there any questions from the audience? Till next speaker is my colleague, Professor Kashyap. She'll be telling us about the pearls of pathology. If there are any questions from the audience, please. So there are many residents in the audience, as I see, and the only way of communicating with you is mainly through the histopathology forms or the cytopathology forms, because I think most of you are quite busy, and like Dr. Rachna had suggested, we should interact more often pre-operatively. That is not possible really. So if the forms are filled up properly, number one. The other thing she said was the labeling. The margins have to be labeled properly. And I would also encourage my senior and junior residents to visit the lab, because the next step after that is the grossing of the specimens. That is the time when we sometimes face problems, which margin is superior, which is lateral. So if the bed in charge or the senior in charge, and I know it's not possible for every case, but for important cases, if you could just coordinate with us, visit the lab, and help us make better sections, and I think it will go a long way in your training as well as for patient care. Dr. Kashyap.
Today I'll be just talking to you about most common lesions in pathology which the postgraduate students must know. I'll not be talking about molecular techniques, but it is just the common lesions which all the PGs ought to be knowing. This is the most frequent question which is asked to me by the residents. Ma'am, tomorrow we have surgery. How do we transport the specimen to the lab? So that's why this has been put as the first slide, that for all specimens should be transported to the lab in 10% formalin, unless you're sending it for frozen sections, enzyme studies, fat studies, molecular studies, then they should be sent in saline. Otherwise, all of them in 10% formalin. And fluids, aqueous and vitreous, there are no fixatives required. For electron microscopy, it's glutaraldehyde, which is the fixative. And cytological studies, 95% alcohol or anhydride. So very important question which the residents keep asking. So 10% formalin is the universal fixative in which you have to send all the specimens to our lab. So I shall be talking to you about showing you just common lesions in every aspect. So some of the intraocular tumors. Now as you know, most common intraocular tumor in children is retinoblastoma. Now what I have shown you over here is the cut section of an eyeball. Now eyeball, whenever we receive an eyeball in the lab, it has to be fixed for at least 24 to 48 hours. Not less than that. It takes a long time to fix. And how do you cut an eyeball? You have to cut from the pupil to the optic nerve. A clean horizontal cut has to be given from the pupil at one end to the optic nerve. And as you can see, this is the cut section which shows the gray-white intraocular tumor, which is a retinoblastoma. And this is the optic nerve, which is a very important structure. We have to take the cut end as well when we are grossing. Now, as regards the histopath, what do we see in a case of retinoblastoma? When we see rosettes, it's known as a well-differentiated retinoblastoma. More than 50% of the tumor, when it consists of rosettes, it's a well-differentiated, and when there are very few rosettes, it's a poorly differentiated. And which are the types of rosettes that we see? Homerite rosettes, as these. There is this pink material and the tumor cells are surrounding this pink material. These are homerite rosettes. These are found in various other tumors as well. Apart from retinoblastoma, they are seen in neuroblastoma, medulloblastoma, ependymoblastoma. So they are not strictly restricted to retinoblastoma. So these are homerite rosettes, not really specific to retinoblastoma, but these are FW or the flex nerve intestinal rosettes, which have a lumen in the center. These are the tumor cells surrounding the lumen, and these are specifically found in retinoblastoma. So well differentiated retinoblastoma, you have to look for rosettes, and these are the florets, which are highly differentiated forms of florets, rosettes, which are seen. This is poorly differentiated retinoblastoma. It's just a small round malignant tumor. There are no rosettes in this. Now why do we give the differentiation? Well differentiated have a good prognosis as compared to poorly differentiated retinoblastoma. That's why it's very important to reports. And sometimes we do have problems when there is a poorly differentiated retinoblastoma, especially when it's in the orbit, it spills onto the orbit and we just have the orbital biopsy. So in those cases, all malignant round cell tumors look the same, you have to resort to immuno, which is seen in synaptophysin. And apart from the rosettes, you have to look for calcification, areas of necrosis. Okay? At times, the surgeons have a diagnostic dilemma. They are not sure whether it is a retinoblastoma or a PHPV or Coats disease. So rarely, but for diagnostic purposes, they do go in for intraocular aspirate. And this is what we see in retinoblastoma, small round malignant cells. And here you can see a rosette as well. So this is a fluid which was sent. Now, as Dr. Rachna had mentioned, that histopath high risk factors are very, very important in case of retinoblastoma. And which are the histopath high risk factors? Optic nerve invasion. Now, this is the optic nerve head. Till here, when you have the tumor, this is the optic nerve head which is involved. Now, this is not considered as a histopath high risk factor. But when the tumor extends beyond this, this is a retrolamellar extension. This is a histopath high risk factors. And here you can see the tumor is in the optic nerve head, retrolamellar area, as well as into the cut end. So again, retrolamellar extension of the tumor and optic nerve cut end, when it is involved, it is histopath high risk factor, which is very important, which is always mentioned in our reports. This is massive choroidal invasion. When more than 3 millimeters of choroidal thickness is involved, it is known as massive choroidal invasion. The difference is you can have focal choroidal invasion also, that is less than 3 millimeters thickness when is involved. It is known as focal choroidal invasion. That is not included as histopath high risk factors. And scleral invasion, see, this is the scleral fibers, and you have the tumor within the sclera, and it can go beyond the sclera also. So scleral invasion, extrascleral invasion, iris, ciliary body, they are all anterior chamber invasion, they are all histopath high risk factors, which should be mentioned, which are always mentioned in our report, so that adjuvant chemotherapy can be given to the patient in order to prevent metastasis. So I've just put down these important features. Now coming on to the next common intraocular tumor in adults. Now this is the cut section of the tumor. Here you have complete retinal detachment, and this is the black tumor which is seen, which is a melanoma. This is the cornea at one end, and this is the optic nerve. So, and this is a whole mount specimen of another case. You can see the classical mushroom shaped tumor and the retinal detachment. And as I told you, sometimes we do find fluids which come to the lab when there is a diagnostic dilemma. This was one such case where we found, which was a very cellular tumor composed of large cells filled with pigment. So this was a epithelioid cell melanoma, which you can diagnose on fluid cytology as well. Now coming to the cell types again, why do we determine the different cell types? Again, cell types are very important to determine the prognostication. Spindle cell type is the most common one. Here you can see spindle shaped cells with a lot of pigment within them, very little pleomorphism and hardly any mitotic figures. These behave in a good fashion. Whereas this is a epithelioid cell type. You can see these large cells with abundant cytoplasm, prominent nucleoli. You have this intracytoplasmic pigment within them, and you have mitotic figures. These have poorer prognosis. And in intermediate group, where you can see a mixed type, this is the epithelioid cell type, and this is the mixed, spindle cell type. So this is spindle, epithelioid, and a mixed cell type, which is, and some, again, we can resort to immunohistochemistry whenever in doubt. HMB45 is positive in melanomas. Again, the key features I have listed. Now coming on to eyelid carcinomas. Now the most common lid carcinomas that we deal with are sebaceous carcinomas, squamous cell carcinomas, and basal cell carcinomas. Now cytology, cytologically, when we aspirate some of the eyelid carcinomas, like this was an aspirate and MGG slide, where you can see a lot of these large cells. These are tumor cells with irregular nuclei and a lot of vacuolation in the cytoplasm. There is a lot of vacuolation in the background also. This was similarly the same case, but a papinicular stain. You can see the prominent nucleoli, large cells with prominent nucleoli. You can see these mitotic figures. How do we say that this is a, how do we confirm the diagnosis? Can I have a answer to this? Sebaceous cell carcinoma, how do we confirm? The answer is over here, oil redo stain. Now can somebody tell me how do we send slides for sections or the sample for oil redo stain? In which fixative do we send? Oil redo, which fixative? You don't send the sample in any fixative, because if you send it in 10% formalin, when it gets processed, the lipid gets washed out. You will never get a oil redo stain positive. You have to send the specimen in saline or as such, and we will cut a frozen section and then do a oil redo stain on that. So always remember, oil redo stain, you have to send the specimen in saline if you have already thought that this could be a sebaceous cell carcinoma. So these are the, this is a bright red lipid which gets bright red color. Here also another case. So some of the histopath sections. Now you can see this is a large tumor island, irregular tumor island. You can see the tumor cells at the periphery. And what are you seeing in the center? This is sebaceous differentiation, normal sebaceous differentiation which you see. When you see large amounts of sebaceous differentiation in the tumor islands, then it is a well-differentiated sebaceous cell carcinoma which has a good prognosis. And you can see the stroma, it's a desmoplastic stroma, a lot of fibrosis and inflammatory cells in the stroma. High power view of the same, one of the islands, you can see a lot of vacuolization. So these are tumor cells which large cells but prominent vacuolization in the cytoplasm. Of course, irregular nucleus, pleomorphism, and as all the other features of malignancy. And in case of poorly differentiated, you can see these numerous mitotic figures, but very little individual cell vacuolation. So such cases you sometimes need to do an oil redo stain in order to confirm whether it is sebaceous cell carcinoma or no. In well differentiated, you don't need to. This is one of the gross specimens of sebaceous cell carcinoma. You can see this grey white tumor outside the in the eyelid, involving one of the eyelids. And what is this? This is the epithelium over here, stratified squamous epithelium. And what are you seeing in the epithelium? This is pagetoid spread which you can see. So pagetoid spread is a very important poor prognostic parameter apart from the large tumor size. This should be always looked for in the slide along with perineural invasion. Another common tumor that we normally encounter in our routine tray, what is this? Pearls. So well differentiated squamous cell carcinoma. This is a very easy slide. When you see the pearls, it's a well differentiated squamous cell carcinoma. Another picture of pearls. Now as you can see, these are again very large cells. You have mitotic figures. They have ample eosinophilic cytoplasm. That's the difference between the sebaceous carcinoma and the squamous cell carcinoma. Here you have a lot of eosinophilic cytoplasm as opposed to sebaceous carcinoma where you had a lot of vacuolation in the cytoplasm. Pleomorphism, mitotic figures, all those features are there of malignancy, but they have important, my God. And this is a poorly differentiated squamous cell carcinoma where you have individual cell keratinization. This was one case where there was intraocular invasion of the tumor cells. Now, when I was talking about sebaceous and squamous cell carcinoma, I thought I'll just put in a word of what is frozen section. The most common indication over here is to know whether the margins are involved or not. The surgeons always send the margins while the patient is still under anesthesia. This is the cryostat machine you will be seeing in some time now when you visit our lab. These are the frozen sections. We have to give a report within 20 to 30 minutes. It's a quick report where we have to mention whether the margins are involved or no. And if one of the margins are involved, the surgeon again sends some more tumor-free margin to be assessed again. So these two were tumor-free margins, and this one of the margins was involved. Impression cytology, just to mention about it, this also you will be seeing in our lab. This is the most common indication is for surface neoplasms, OSSNs, for dysplastic conditions, for ulcerating lid lesions, and most importantly for dry eye. Like you have these millipore filter papers which are cut into strips, and again 2 or 3 strips, and this is dabbed onto the lesion, and after a few minutes they're peeled off and put it into the Coplin jar containing 95% alcohol and then stained with hematoxylin and eosin. So to show you some examples, these are benign squamous epithelial cells, and here these are dysplastic cells, mild to moderate dysplasia, and in this particular slide, severe dysplasia. You can even see a pearl over here. You can also diagnose sebaceous cell carcinoma. You can see vacuolation in the cytoplasm. And goblet cells in dry eye is an important indication for this particular impression cytology. Here these are goblet cells, large cells. And sometimes when you are not very experienced enough to pick up on HNE, you can also do PAR stain, which brings out the goblet cells very well. The last one was BCC. Now BCC, you can see this is a stratified squamous epithelium, and from the basal layer you have this tumor which is arising into the subepithelium, which has a characteristic palisading, peripheral palisading. You can see this peripheral palisading in all these, in the high part, the peripheral palisading is brought out very well. So this was a BCC. I don't know whether I can continue with this. I just wanted to show some of the common lesions.
I think we've got 2 more speakers.
Yeah, so I think I shall just skip over these. I have a couple of more slides, so I think I can discontinue over here.
I think maybe another time.
Okay.
Another session.
I'll just, this is pleomorphic adenoma, biphasic tumor, epithelial and the stromal element. This is ACC, classical Swiss cheese pattern, a punched out appearance, and this is the perineural invasion. This is C-kit, which is used as an immunohistochemical stain. Vascular lesions, cavernous hemangioma, and this is a capillary hemangioma, just slit-like vascular spaces. Lymphangioma, you have these lymphoid aggregates and filled with lymph within the vascular spaces. I think there are a couple of more slides.
Pathology's got a wealth of pictures, but
Yeah.
I think we'll have to put a full stop.
Yeah, okay. So I think I shall stop over here.
Thank you, Dr. Kashyap, for such beautiful slides. It was indeed a feast for the eye. Thank you very much. Now I invite Jayanti. Jayanti is a postgraduate student in our lab under Professor Kashyap, and she will be talking about the translational aspect of pathology, which is now gaining much importance, as was told by Dr. Rachna also. So how we can effectively use the polymerase chain reaction in the management of choroidal melanomas.
Hello everyone. I'm going to present about real-time PCR in ocular melanoma. So this is the cut section of the eye representing choroidal melanoma. For sample collection, we take the tumor and we put it in, which comes from the operation theater in saline, and then we take the samples and put it in RNA letter. It is a preservative medium and can store it in -20 degrees Celsius for the longer period of time. So to homogenize the tissue, like we need to crush the tissue, we take 25 mg of tumor, and this is the homogenizer. Using this homogenizer, we crush the tissue for the sample extraction. So for RNA extraction RNA extraction is done using this kit according to the manufacturer's instruction. Then from the RNA, cDNA is prepared again using the this thermoscientific verso kit. So what happens that this is the mRNA, which is single-stranded, which is converted into the single-stranded DNA, and using this kit we can get complementary DNA, which is double-stranded. Now this cDNA can be used in the polymerase chain reaction. So what is polymerase chain reaction? Here any sequence within a DNA or cDNA can be copied or amplified many thousand times to a million-fold. So these are the components which are required for the PCR DNA samples. Primers, which are complementary to the DNA strand and binds to the strand for the amplification, and then buffers. We mix it in the PCR tube and can be used for the PCR. So this is the whole cycle which is used in PCR. The first step is denaturation, that is the two strands get separated at higher temperature. Then next step is annealing, where primers, they binds to the single strand, and then extension, where primers are extended, and then we get two double-stranded DNA from the single strand. This is the amplification. So this is the PCR machine which we are using in our lab, and the results which we get from the PCR can be visualized through agarose gel preparation, where ETBR, that is ethidium bromide, is used. It is through fluorescence under UV light. And through this machine, it takes around 3 hours. And now what is real-time PCR? So this real-time PCR is the variation of that standard PCR technique that is used to quantify RNA. So amount of RNA is measured here via fluorescence. So these fluorescent dyes are attached to the primers that hybridize with that PCR products. So increasing fluorescent signals is directly proportional to the number of PCR products generated. So there are two kinds of dye which can be used. First is cybergreen, and then second is TACMAN. In cybergreen assay, when there is the extension of the primer, and there is the formation of double-stranded DNA, the cybergreen attaches to that double-stranded DNA and give fluorescence. That's how we can quantify that how much strands, how much there is expression of any gene. In TACMAN assay, there is a probe which we use, which is complementary to the single-stranded DNA, and then when the primer in the extension process, when primers comes to the close proximity of that probe, the reporter dye cleaves off, and then fluorescence signals takes place. So TACMAN probe is more specific than cybergreen probe. So this whole cycle of real-time PCR is same as PCR, but it takes place around in nearly half the time of the conventional PCR, that is 1.5 hours. This is the machine which we used in our lab, and here the results, these are visualized in the form of amplification plot. So what is the difference between the PCR and real-time PCR? So PCR is just polymerase chain reaction just for amplification, and qPCR, also known as quantitative PCR, here we can quantify that how much expression of any gene is taking place. Now in PCR it is non-fluorescence and only primers are used. In qPCR dyes are used, which is fluorescence based. Again, there is the differences in the mixture of buffers in the PCR and qPCR. Then end results, they can be visualized on gels in PCR, whereas in qPCR it is visualized on the basis of graphs and then calculations. In PCR, it is low resolution amplification. In qPCR, it is high resolution. So when in the amplification plot of real-time PCR, there is the threshold phase, then exponential phase, and then plateau phase. The calculation is based on CT value. CT value is the number of cycles takes place for any gene to give fluorescence or to express. If there is high CT value, that means the expression of gene is very low. And if the CT value is low, that means expression of gene is very high. So on the basis of CT value, we can calculate that whether any gene is downregulated or upregulated. So this is the paper which we have published, in which we have shown the TRP1 expression through real-time PCR in uveal melanoma. So as we know that as pigmentation increases, cancer risk decreases, but according to many literature, it has been shown that pigmentation is not a protective mechanism, but it is a risk factor for the development of UM in white population. And it also shows worse prognosis of uveal melanoma in white population. So TRP1, it is responsible in the melanogenesis pathway or the synthesis of melanin. So we have shown that in comparison to normal uveal tissue, there was high TRP1 expression in uveal melanoma, as well as there is high expression of HIF1 alpha, that is hypoxia marker, which this and the expression of Yes, so expression of TRP1 and HIF1 alpha, they both were correlated with high pigmentation and BAP1 loss. So BAP1 loss is the known marker for the uveal melanoma. So there is next paper also we have published on the basis of DNA damage response protein, that is ATR, in uveal melanoma, where we have shown that in comparison to normal uveal tissue, the DNA damage response was low, that is expression of ATR was low in uveal melanoma. And it has been also correlated with advanced tumor staging, tumor thickness, metastasis, BAP1 loss, as well as necrosis. So these are some of the clinical significance of real-time PCR. There is rapid detection of the biomarkers even with the small sample size. It is efficient technique as large cohort of patient sample can be processed at a single time. Effect of drug therapy can be also evaluated. We can do genotyping, that is multiplex PCR, we can check expression of genes at a single time. Then we can do DNA damage measurement also. Thank you.
Thank you, Jayanti, for telling us the translational aspect of uveal melanomas. And we hope to carry this forward, and I hope it is going to benefit the patients in future when we use the PCR technique in all our ocular malignancies. Thank you. So we now move on to our last speaker. He is Dr. Jayaraj. He is a faculty from Delhi University. He completed his PhD in 2011 in our department, and he has continued his passion for ocular oncology. And so today he'll be presenting one aspect of ocular oncology, which is the chorioallantoic membrane, which is an in vivo model for doing research in ocular malignancies.
Yes.
Thank you, Jayaraj.
Thank you so much for the introduction, ma'am, and I'm very delighted to be here, and tensed also, because it feels like another Viva for me. So I hope the association that the department has given to me has led to some interesting work, and this is a research-based work that I'll be currently presenting, but it has certain impacts that depends on how we carry it forward. So the model of the model organism that I took for the research is chick, as the name suggests, and we'll be using the chorioallantoic membrane. It's a membrane, as the name suggests. It's a membrane, it's a protective layer, as we know from our earlier studies, like there are amnion, chorion, allantois, and the yolk sac, which have a protective barrier. But what we have to utilize is the chorioallantoic membrane, which fuses with the eggshell membrane that, as you can, I don't know, does it work this way? Okay. As you can see that the chorioallantois kind of fuses with the eggshell membrane. Now we will be using this property or the membrane to assess whether rare tumors can invade or get into the chick, or whether it is able to enter into the chorioallantoic membrane. This will help us in understanding the fact that okay, your tumor cells have the capability or have the invasive capability of crossing the basement membrane and invading the blood vessels. So we have to visualize this and we have to prove it. The problem with ocular tumor is we consider as a rare tumor because we have less number of tumor samples. So we have another way of doing it is either using a cell line, but what we have done in our research work is directly getting the tumor from the patients and using the tumor as such on the chorioallantic membrane so that it gives a better representation. This is just an early view of just to have a pictorial understanding of what the extraembryonic membrane is. So what you can see over here, in the chick embryo, the chorioallantois fuses and it has a rich supply of blood vessels, and we have to somehow access this region and put our tumor samples, and we have to ask the question whether it is able to cross the membrane, the extraembryonic membrane, and reach the different areas of the chick, or it is not able to do so, and that gives us an analysis of whether the tumor is highly invasive or not. So we have taken 2 tumors in our study. One is melanoma and other one is retinoblastoma. In these pictures, I just wanted to say before we carry out these things, we need to get the chick embryo first, which should be fertilized, and we should have an understanding of how the chick development looks like. So there is something known as Hamilton stages, in which you need to understand the developmental days so that you can plant the tumor samples at the appropriate stage when the chorioallantois is well developed. So I'll be not going to the detail. This is how you open up the chick embryo and you kind of know what day it is. Around day 7 you have to implant, and the chorioallantois, here the entire chick embryo has been removed to show you different compartments like the amnion and the allantois and the chorioallantic membrane. We have to use this membrane to assess our penetrability of the tumor. Okay, so this is a pictorial representation of the same. So what we have to do first is something known as candling, which tells us whether how much blood supply is there. Once we know that there is formation of the chorioallantic membrane, as you can see over here, we can open up this eggshell and we can implant either cell lines or patient-derived tumors. Patient-derived xenografts would be meaning taking the tumor directly from the patient and putting on the egg membrane, and want to ask the question whether it will invade the different regions of the chick. Now the problem is we are using a human cell and we are asking a question, if it invades the chick embryo, how will you differentiate between that? I'll answer that in the following slides. Okay, so what we did was we took 2 majorly involved invasive retinoblastoma and uveal melanoma, and we wanted to figure out whether we can use this model for other tumors like squamous cell carcinoma and sebaceous gland carcinoma, because the so retinoblastoma is highly invasive. So I will be not going into the detail of it because other speakers have already spoken about it. We know that it's really highly invasive and it can reach the other sides of the body. Now we have to understand why it does so and how it does so. Another aspect is uveal melanoma, another very malignant tumor which can metastasize to liver and other regions of the body, but there can be other grades, as like the speakers have already talked about. There are certain grades of tumor that you have to identify whether they are high grade or low grade tumors. Okay, so what is patient-derived xenograft? Patient-derived xenograft are those grafts which you actually take from the patient directly in saline, which has been told by all, so that it retains the original tumor property. Generally, we use this tumor and put it inside a nude mice, which does not have an immune system of its own, and it allows the tumor to grow. But the problem with the mice is the handling. You have to have an animal husbandry lab, you have to maintain it, you have to make sure that the animal survives for the duration of the research work. But chick embryo reduces all the time because of its 21-day development. By day 10 or 15, you will be able to understand whether the tumor cells have invasive properties or not. So just to demonstrate that, first thing you have to get a fertilized egg, make sure the egg is fertilized, that's the first case. Then we have to identify whether the chorioallantoic membrane is formed. You just have to take a torchlight and show it to the egg. It will show whether the blood vessels are there inside or not. Then you open up the chamber, and what you'll figure out is this blood vessel, rich blood vessel, and you have to take the tumor samples and deposit on appropriate area of development. How you do so is by wiping the egg and putting a silicone ring on top, so that you put the tumor between the silicone ring so that it does not move here and there. Then after a certain day of development, you will find 2-3 things: whether the tumor is not grown at all, whether it is causing some blood vessels to reach over it and it has angiogenetic property, or whether it has invaded. To understand invasion, angiogenesis you can see from the outside. Why we can see from the outside? Because the blood vessels, number of blood vessels will be increasing toward the tumor area. Okay, this is a visual interpretation. But to understand what's happening on the inside, you have to dissect up the chorial lymphatic membrane and go for histopathology. And another thing, another problem is to differentiate between the chick egg and our own cell. So we need to have different markers for doing that. This is just a series of pictures just to show you. At appropriate days, you have to incubate it, put the tumor samples in the between the silicone ring, and wait for things to happen. Okay. So now the few questions is whether it is going to go into different regions of the chick embryo. We have to take out all the organs and tissues, and we have to go for histopathology analysis. Or if you are thinking it has gone into the blood, then we have to take out the tumor or the blood sample, and you have to do a specific PCR that will tell you whether this is a genome of a chick or it's a genome of a human, to make sure you have invasiveness. Okay, so I'll be showing just few examples here. Now, how does the chorial lymphatic membrane looks like? That should be the first thing that we need to know. When you excise the chorial lymphatic membrane, you will form a chorionic ectoderm and allantoic endoderm, and in between it is the mesodermal space there, and you can see there is a blood vessel. This is the normal structure. Now, within this structure, you have to identify whether the tumor has invaded. That is the first step. Okay, this is again a different view. That was a thicker view. These are other regions. So first thing we have to understand is how the normal structure looks like, so that we can understand how the abnormal or the invasive cell you will be able to identify. I think everybody, we take the gross samples fresh in saline as soon as possible, within like say 2 to 3 hours of operation. Then what we do is we take out the fresh tumor sample. It should be lesser than the size of the silicone ring, and we place the tumor, and you can see once we are done and incubated, there are a lot big. So melanoma, it makes angiogenetic molecules. So it makes the blood vessels to reach towards it so that it can metastasize. So here in which we can prove, if you put a drug or any other thing, we will be able to understand whether you can prevent it or not. For now, we are just showing you, okay, it attracts the blood vessels because it has to metastasize into the cam or to the chick embryo. This is the top side, this is the bottom end, this is the top end. You can clearly see there are new blood vessels which are creeping in towards the melanoma samples. Now, how to visualize it? So this is the normal chorial epithelium. You can see there is endoderm, ectoderm, and the mesoderm, and the normal blood vessel. Now we have placed our tumor samples over here. This is the melanoma. Why we preferred melanoma is it's already pigmented. So we took choroidal melanoma so that you can see the pigments are there, and it is easy for detection in during the histopathology. So we did that. This is the normal HE stain to make sure there are enough melanin pigments for a study. This is the final result. What you can identify is, if you are familiar with this picture, you can make sure that this is your chorial lymphatic membrane, and this is your ectoderm, this is endoderm, in between is the mesoderm, and lying over here are the blood vessels. Now you can see this is the tumor sample which we implanted. After 4 or 5 days, you can see this melanoma has invaded the mesoderm, and it is now capable. Now if you leave it or if you culture it further, you will able to understand whether it is going to reach other organs or it is just going to stay there. But for now, we have proved for the first time that if you take tumor samples directly from the patient, we can do that. We don't have to rely on cell lines, because tumor samples are coming from a patient. The tumor samples are heterogeneous. It has multiple cell types. But when you take cell lines, they are all clones of each other. So if you want to do a personalized medicine, you have to work on the tumor from the patient, so that nowadays people are working on PCRs and RT-PCRs specifically for personalized medicine. So you can understand the type of tumor and the metastatic ability of the tumor, and you can decide upon the treatment strategies. Similarly, we did this analysis for retinoblastoma. Here you can say again, it is a tumor which is highly invasive, as others have already discussed, and you can see there are many blood vessels which are forming. Because retinoblastoma is non-pigmented in this case, you are not able to see the tumor in as good clarity, but you can obviously find that there is a ring of blood vessel reaching into the retinoblastoma. So this proves what you are seeing in your histopath side. Yes, these tumors are very much dangerous. They have the capability of invasion. So this is a proof of like you can say, okay, it can happen. Okay, now the problem with retinoblastoma is again the visualization. So we use specific immunohistochemical, we do immunohistochemistry, and we use specific like antibodies, like here cyanotophysin, sorry for this, cyanotophysin was used. So what we did was to differentiate between the chick membrane and our deposited cell. When we did our IHC, we found that certain cells were adhering to the epithelium right now, and few cells are trying to reach in. And here in this case again, we see that the retinoblastoma is still intact on the epithelial membrane, and some invasion has taken place. But it is in melanoma, it's very aggressive. You can still see that it has reached the mesoderm. Okay. So to discuss and conclude, so we have right now in our lab developing a strategy to understand the tumor behavior. We have taken classic tumor like retinoblastoma and melanoma to make you understand, okay, this is what is happening, but our aim is to go for other rare tumors and understand their metastatic ability. Like sebaceous cancer and squamous cancer, they show local invasion, but sometimes sebaceous cancer can lead to tumors like tumor deposits in different parts. So we have to make sure and bring about a lot of research papers that will talk about the metastatic ability, and people will take these tumors more seriously and put more research fundings on these tumors, which is less right now. So, so what else you can do is first we have to optimize for, like we have done optimization for UL melanoma, and we have done optimization for retinoblastoma. Similarly, you can use it for cell lines, you can use it for other tumors, whichever you think has an ability to cause angiogenesis and other factors. You can do size and weight measurement, whether the tumor is increasing in size, how much is it doing so, what is the property of the growth, because some of the tumors are locally invisible, they will just grow in that side. Okay, and you can work on different IHC markers to understand which IHC markers are indicator of metastasis. Okay, thank you. All right, so all these would lead to individualized treatment, because we are not working on cell lines, we are working on a tumor from a patient, and we are talking about that particular patient only. We are not generalizing the fact that melanoma cell lines will invade. We are now telling, okay, this particular patient's tumor sample has the invasive ability. Okay, I'd like to acknowledge my mentors, Professor Seema Sen and Professor Seema Kashyap, and students and staff of Dr. RP Center Pathology, who allow me to visit the lab anytime I want, and they are open up to research interest. I'm able to do academics as well as research because of their guidance and support. And thank you, RPC, for having me. Thank you so much.
Thank you, Jairaj, for your excellent presentation. So as you can see now, pathology is a very wide spectrum, starting from the wonderful diagnostic aspects which were covered by Professor Kashyap, then moving on to the research aspects covered by Jayanti and Dr. Jairaj. So with this, we come to the end of ocular pathology session. I think we are running short of time. If there are any pressing questions, maybe one from the audience for any of our speakers.
I just wanted to comment that for the residents also, it is also very important for them to know the pathology, and it's a big joy for a clinician when the diagnosis gets confirmed by the pathologist. Like I even remember the first case where I might have suspected a primary vitreoretinal lymphoma, and I might have sent a cytology to ma'am or ma'am, and then gone up and seen the actual lymphoma cells, and when you are able to prove it that yes, clinically this was the sign in the patient, you suspected it, and actually the patient has it, and then you are going to treat the patient in the correct manner. So it does give you a lot of joy. And so definitely I would suggest that you also go up and have a look at the slides of your patients. When you confirm the diagnosis, you become much more involved with the case and you realize the importance of the pathology itself. So, and like everyone has mentioned, you must be aware of how the samples have to be sent. That is very important because these cells are very friable, and unless you send them immediately for cytology, you're going to damage them. And lastly, I think a very interesting research project by him. So I just a simple question I thought, when you were putting the cells there and you were trying to show all the invasion, but did you ever find a local growth of the tumor there, like we actually see a choroidal melanoma or a retinoblastoma?
Sir, the tumor sample stays there. Okay, whatever is happening happening on the inside. Like
it doesn't grow as a nodule there.
It will grow in size. So there are, I did not show the images of how to measure the tumor sample. So there are ways to study angiodentic properties so that we can count the number of blood vessels reaching it. And we can, if you have taken the original size of the tumor that you have put in, then we can use computer technologies like to understand how much increase there is in the size. So,
thank you. Thank you, very nice.
Thank you, Dr. Rohan, for telling the students to visit the lab, and it's indeed a pleasure to see the slides under the microscope on your own. Thank you. So I think now we can move on to the ocular microbiology session, and I invite Dr. Nishat to give her first talk on ocular microbiology from basics to advanced.
Welcome you all to the session of microbiology, and in this session we will have a glimpse of some of the important activities which the ocular microbiology section is involved in. We start with the first talk, ocular microbiological diagnostics, basics to advanced. So So the first question which we need to answer is, why should we have a microbiological diagnosis at all? It is understood that some of the pathogens, they give some clinical signs and symptoms which are specific of that particular infection, but most of the times there is an overlap of clinical features, and with clinical examination alone it is not a conclusive diagnosis. Also, mixed infections are very common and each one of them needs to be treated. And specifically in tertiary care centers like ours, modified manifestations of infections are seen in case of partial treatment, and also a lot of our patients are immunocompromised where a typical presentation of a particular infection is not seen. Also, drug resistance is very high these days, and we need to know the resistance pattern before we completely cure a particular patient of the infection. And while all this is going on, it is important to understand that the time to intervention is very less, because incorrect treatment can be fatal to the eye in terms of loss of sight to the patient, and important emergencies are ophthalmia neonatorum, endophthalmitis, orbital cellulitis, also perforated corneal ulcers, to name few. So we'll start with the microbiological diagnosis, conventional first, and the most important thing is sample collection. So in any infectious disease, and so also for ocular infections, the sample should be collected as far as possible before starting any treatment, specifically any antimicrobial or steroid, because they interfere with the yield of the culture, which is the mainstay of diagnosis of microbiological diagnostics. So depending upon various types of infections, the type of sample should be collected from the site of infection, and these are the recommended devices and procedures for all the infections. The most common specimens which are collected by the residents are conjunctival swabs and corneal scrapings. So we will briefly look at them. For collecting a conjunctival swab, the patient is asked to look up, and the lower lid is gently pulled down to expose the inferior palpebral conjunctiva, and this is a sterile swab. We have to pre-wet it with sterile saline, and then we have to sweep it along with the rolling motion of the swab from inner to the outer canthus. And the swab should be immediately inoculated on the culture medium, or it should be smeared on the slide for microscopy immediately. In case of dexterous cystitis, there is a small change that the pre-wetted sterile swab stick is swept along with the rolling motion from the lateral to the medial canthus, because in the medial canthus there is a lot of pus collection, and also regurgitation can be elicited many of the times by pressing the medial canthus, and that fresh pus needs to be collected for microbiological diagnosis. Also for chlamydia, the sample needs to be taken from upper tarsal conjunctiva, because that is where most of the organisms are seen, and that is done by exposing the upper lid, by everting the upper lid, and again with the same technique a swab is taken. A corneal scraping should always be taken under slit lamp or microscope, and a topical anesthetic agent should be instilled. It should be preferably without preservatives, because preservatives again they will interfere with the yield of the organism, and it should be allowed to act for 30 seconds. And ideally using a chimera spatula or surgical blade, the sample should be collected from the advancing border of the ulcer, and again it should be immediately inoculated or smeared. Talking of the corneal scraping specimen, it is also important to understand when you are doing the patient side inoculation, inoculation is done in C-shaped streaks like this, because sometimes the colonies are so few in corneal specimen, it is a dry and very small specimen, that it is difficult to differentiate it from the contamination which might occur in the plate. So if the growth is occurring in these C-shaped patterns, then we know that it is from the specimen which we have inoculated. We will show you these patterns of inoculation during your demonstration round as well. Now these are the 4 pillars of diagnostic modalities in microbiology: microscopy, culture and identification, immunodiagnostic methods, and molecular methods. And a primary microscopy is one which is done directly from the clinical specimen, and it guides us for empirical diagnosis and an evidence-based empirical treatment of the patient. In this, we see the presence of microorganism as it is in the clinical specimen, and also the type of inflammatory response it is producing. These are the various microscopy techniques which are used in microbiology, and gram stain and KOH mount are routinely done for all the specimens. We will just quickly go through that. In gram stain, we all know this, that after fixation of the smear, the slide is flooded first with crystal violet, then iodine, and then decolorization is done, followed by counter staining with safranin. The gram-positive organisms appear purple-violet, and gram-negative organisms appear pink because of the presence of a thick peptidoglycan layer in cell wall of gram-positive bacteria and acidic protoplasm in gram-positive bacteria. As a result of these two, the bonding of the stain with the organism is very strong. Along with thinner peptidoglycan layer and less acidic protoplasm in gram-negative bacteria, as a result of which the bond is not so strong, there is high lipid content in the cell wall of gram-negative bacteria, so that when we put an organic decolorizer, all the dye, it quickly flows off with the lipid content of the cell wall. That is why these decolorize faster and they take the counter stain to appear pink in color. And these are some examples of microscopy by gram stain. This is a case of staphylococcal endophthalmitis. We are able to see gram-positive cocaine clusters and a lot of inflammatory response due to infection. This is a case of pneumococcal dacrocystitis. We are able to see gram-positive cocci in pairs, and we are even able to see a clear halo around the organism, which is suggestive of a capsule. And then there is inflammatory response again. This is a case of conjunctivitis caused by gram-negative bacilli. This is a case of gonococcal conjunctivitis. We are able to see enormous acute inflammatory response and gram-negative cocci in pairs, mostly intracellular, some extracellular. This is again a gram stain smear. We are able to see candida. This was again a case of endophthalmitis where we were able to see some pus cells, budding yeast cells, and pseudohyphae. The next important thing which we do is the KOH mount, or called potassium hydroxide mount, also called KOH mount. Now this is for the visualization of fungal elements. So potassium hydroxide, it digests all the animal cells and it allows the fungal elements to stand out, and this is how they look on the mount. So everything else has got digested after some time of incubation, and the septate fungal hyphae, hyaline fungal hyphae, are seen in this picture. Adding calcofluor to KOH mount, it increases the sensitivity, but it requires the use of fluorescence microscope. We are again able to see these fluorescent septate hyphae. Next very important thing in microbiology is culture and identification, where the clinical specimen is cultured on suitable growth media and identification is done using various procedures. So as we saw in the sample collection also, that direct inoculation at the site is preferred. And these are the media which are used for bacterial, fungal and acanthamoeba culture. Virus and chlamydia, we know that we cannot grow them on artificial media, so we use tissue culture for them. This is a growth of bacteria on blood agar, fungal growth. This is the growth of acanthamoeba on non-nutrient agar. We have these things in demonstration also. And this is an example of tissue culture cell lines. This diffusion technique is routinely used for doing antimicrobial susceptibility testing. Next are immunodiagnostic methods, where we exploit the specific nature of antigen-antibody reactions for detection of either antigen or antibody in the patient specimen to diagnose a condition. Antigen detection is routinely done for herpes, diagnosis of herpes infection in the eye and chlamydial infections. Antibody detection has use in ocular infections only where systemic infections are causing ocular manifestations, for example toxoplasmosis, syphilis, cytomegalovirus, etc. Now molecular methods, we have seen the details of the procedures, and in ocular infections they find use only in organisms which we are not able to culture or see under the microscope, and polymerase chain reaction is the most popular one for ocular infections. And in ocular infections, all the molecular methods are very sensitive and specific. They have few limitations because otherwise we are diagnosing infections based on semi-quantitative techniques. Here we cannot quantify because everything is getting amplified before getting detected. So we don't know what are the counts of the organism in the specimen. Also, non-viable pathogen can also sometimes give a positive reaction because we are finding the genome of the organism. Also, because in differential of infectious conditions, the number of organisms is so high, it is very difficult to put different reactions for all the organisms. So the interpretation is very tedious and cautious in such cases. So at least for bacteria and fungi, molecular methods are not able to replace the conventional methods as of now. Now we move on to the advanced diagnosis, and next generation sequencing is one where we have some experience. In this, the genome of the pathogen, it is sequenced, and the sequence of the genes obtained, it is matched with software containing sequence of various pathogens and their characteristics. So with that matching, we can identify a pathogen, we can find out whether it is resistant, what virulence factors it has, because everything which is occurring, which the organism is causing, it is as a result of something in the genome. So if you sequence that, you can find what characteristics it is going to have. Next, this is something which we did for diagnosing ocular viral infections. We established a multiplex PCR where in a single reaction we can find out herpes simplex virus 1, 2, adenovirus, cytomegalovirus and varicella zoster virus. And in this multiplex PCR, we not only found very good sensitivity and specificity, we also found it very useful to be very useful in tear samples, and also we could diagnose a lot of posterior segment cases. And now we are diagnosing all our viral infections using this multiplex PCR. Next is the automated sterile fluid culture system, or BACTEC 9050. Actually, this is an automated culture system in which the growth can be alarmed by the machine. And it finds its basic use for detecting the presence of microorganisms in blood and sterile body fluids. We used it for our vitreous specimens because they are also semi-liquid and they are sterile samples also. And we were able to identify with conventional culture around 18% of the bacterial pathogens, but with this we were able to identify bacterial pathogens in 31% of the cases, so it was found to be useful. We have this machine and we are planning to again use it for the patients on a routine basis as well. This is an identification system which is automated, Vitek 2 compact, and again these are the cassettes which are used for the organisms, and based on the pattern which is produced by the growth of the organism in this cassette, some data is generated which is matched with the library for identification of the microorganism. And this is Malditov. This is the latest and very useful of the automated techniques for identification of organisms. In this, what happens is that the growth is mixed with a matrix, and the organism, it is annihilated into its smallest components. Then these components, they are run through an electrostatic field and ejected through a metal tube subjected to vacuum to reach a detector. So the smaller ions travel faster than the larger ions. So based on the identification of what the analyte is, how much time it is taking, where it is hitting the other end of the tube, a pattern is created which is again matched with the library in the software to identify the organism. So these were the diagnostic techniques which we are using for diagnosing viral or ocular infections. And because as a microbiology section, we take immense pride in being involved in the infection prevention and control activities of the center, which are mainly centered around the safety of the patients and healthcare workers. We take care of the correctness of the environment in various areas, the disinfection of surfaces, sterilization of instruments. We do surveillance of infection control practices and also do biomedical waste management and investigations of outbreaks of infections. And whatever we are able to do, the whole team of microbiology section is involved, and I am always full of gratitude for their hard work and their support towards the center. Thank you for your kind attention.
Thank you, Dr. Nishat, for presenting the basics right from sample collection right up to the molecular aspects of microbiology. If there are one or two questions, quick questions from the audience, we can take them. Yes, I can see one hand.
Many times it will be sent after overnight storage.
So that is the message, that if you send a sample which you collect at night and then you bring in the morning, then that is not the correct procedure. So it is always advisable, and we are very pro into that if you are having, if you are wanting to collect a sample towards evening when the section is closed, then please keep some culture media with you. You can identify the patient with us, that for this patient we are wanting to take the medium, and you inoculate it, keep it in incubator, and then next day you can bring to us. Okay?
So I think now we can move on to the next speaker. Now invite Dr. Rohan Chawla. He will give us a talk on cluster and endophthalmitis, which is very important from the hospital and the patient point of view.
Thank you, ma'am. So you might be thinking that I'm a retina surgeon, and so I'll probably be talking more on the individual endophthalmitis management part of the patient. But no, today I'm not here to talk about the individual management of each endophthalmitis patient, but more about what to do if we have more than one such patient in a single OT. So if we have a cluster. So what is a cluster? So classically it has been defined as having more than 5 cases on a particular day in a single operating room. Some authors define it as more than 3. So I would say that I would keep the threshold low. 3 is also good enough number to call it a cluster. Why wait for 5 cases? And difference between a cluster and the individual cases might be a microbiological difference. Individual case the causative organism might be from the flora of the patient itself, generally a gram positive, whereas in a cluster generally they are non-commensals and they also might be gram negative organisms. So earlier we used to get clusters when there were camp surgeries being held and cataract surgery was the most common, but now it falls in our realm because intravitreal procedures have become the #1 surgical procedure being performed worldwide. And unfortunately these intravitreal injections also are done with the patients are grouped together, and that is why we have a huge surge in endophthalmitis happening post injection. Incidence is up to 0.05, and there is a slight variation with the drug, definitely steroids leading to a higher incidence, but even with anti-VEGF agents we do get clusters of endophthalmitis. So what are the risk factors? They are almost as common as any endophthalmitis, but specifically if we look at them, they can be OT related, they can be the protocol where how you are giving the injection, drug related, surgeon related, as well as patient related factors. So we'll go into one by one. Okay, some statistics. So it has been shown that about majority of cases are because of contaminated solutions. So please, even when you are out there in the practice, do not buy substandard solutions, because many of them would have growths which you would not even know, and they are a very common cause of this. And even in our center, in one outbreak, we found that the povidone iodine itself, Dr. Nishat had found out that povidone iodine was ineffective, and because of that the organisms were still growing. And in another of my experiences, even in a very good private setup where I had worked, the problem was with the ventilation system. There was a AC from where the organism was cultured, and that was the cause of a break of 3-4 cases from that OT. So there can be other causes like this. So these are all the things which are common, and these are all the things which you would have to look into if you get such an outbreak. So in India we are doing intravitreal procedures mostly in an OT setting, not in an like a clean room. In Western countries they are doing it in a clean room, but here we are doing it in an OT setting. So we have to look into whether there is any compromise in the OT sterility, starting from all your autoclaves, AC systems, and one important factor which Dr. Vilpandian has mentioned recently is the air turnover time. So you need to have give some breathing time to the OT so that the air is fresh over there. Even if you have put a HEPA filter, if you are having too much of movement in the OT, the air is going to be contaminated. What will your filter do? And then you are going to get infections. So you have to see what is the turnover time. Is the HEPA filter able to take care of it or not? You should not have overcrowding in the OT. You should not have 20 residents watching one surgery. And another problem here is insects. So you have to have insect repellents, and you cannot just afford it. And you might be laughing, but we do see sometimes insects in our OT. And because we have our doors opening and closing so often, because we have such a big patient load. But that is something we need to look into if we have to prevent these problems. Then while you are administering the injection, the betadine contact time, various studies would say some 3 minutes, 1 minute, but I would say let us follow the standard one which most textbooks say it is a 3-minute contact time, which is essential for reducing about more than 95% of the flora. And no eye drops to be instilled after your final betadine. So sometimes you might put in a Tropicacil plus, or you might put in Paracaine after that, but if that drop, that bottle tip is not sterile, you are again introducing an organism over there. Then proper draping of the patient, and with the lashes, the lid margins are again a very common source of infection. So if you are properly draping the patient, you are solving the problem partly. And use separate sterile syringes and needles. Do not load about say 2 ml of drug in one syringe, and since you have to give only 0.1 ml, you are using it the same one for 20 patients. So that is not again an accepted habit. It is done by some. So please, again I am emphasizing that is not at all to be done. So this is how your proper draping should be. So first you clean the lid margins 5-6 times, because this is the maximum amount of flora you are going to have here. Then you go all around. You are not going to come back in the central field, and you have to clean up till the hairline, and below you should clean up till the lip margin, and then put a nice drape which is covering all the lashes so that none of your instruments are going to come in the way. Then there can be drug related factors. Unfortunately, the company which makes Avastin does not give us single vials, so we have to make it here, And we are very fortunate that we have this facility in pharmacology where we can make this under a class 10 facility, which is a very sterile facility. And if you do not have this facility, then the other guidelines given by AIOS and VRSIR either store in 1 ml syringes which are prepared under a laminar hood or in the operation theatre, and again stored in a sterile container, but do not store them for long. Again, maybe I think 1 week or 10 days is the time period they have prescribed. Or you pool patients and not more than 7 on the same day and use a vial. You puncture it, withdraw it and divide it into 7 separate syringes, give the injection and discard the vial. Don't keep reusing the vial again and again. But purchase these drugs from again standard dealers, maintain the cold chain and use within the date of expiry. So this is thanks to Dr. Velpandian, our facility here where we prepare these aliquots, and fortunately we have had quite a very few infections. Some infections would occur in any department, but yes, we have the number of injections that we give is quite huge. So these are again very important. Surgeons should not be suffering from any infection. Proper scrubbing and OT etiquettes. So I do find some residents just scrubbing once or twice and entering the OT. No, it has to be 5 minutes. If you are entering the OT for the first time, first case, it has to be 5 minutes. Many operation theatres have a clock there and you have to follow it by the clock. Second wash maybe 3 minutes, but first wash I would say has to be 5 minutes. Don't speak too much in the OT. There have been cases where they have cultured your throat streptococcus from the patient's eye. So you do not speak too much, and you have to put a face mask. And then there is another study which says that do not put a face mask on the patient, because they have shown that if the patient puts a face mask, the airflow is directed upwards and the flora can go to the eye. So no mask for the patient, but definitely mask for the doctor, and no talking for the doctors, less talking for the doctors. And again, please, when you are wearing a sterile gown, how you walk around on the OT is very important. The only sterile area is from your clavicle up to maybe mid-waist. So I see residents putting their hands in the pockets of the gown. I don't know who designed those pockets. It's a totally design failure. There should be no pockets there. How can you put your hands in your pockets and stand in the operation theatre? Your hands have to be right here, straight. You cannot even have your hands like this. If you touch some surface, then you are unsterile. You have to wash again. You cannot put the recording on, recording off, change your gloves and then go back. That is not the done thing. You might be doing it, but I'm just telling you that is not the done thing. OT etiquettes are OT etiquettes. You cannot afford a single infection today. When the medico-legal cases are too much on the rise, you get a single infection in private practice, you are going to have a big problem. Not just that, for the patient point of view also, why should a patient get an infection when he is under your care? So you have to have all these, take all these precautions. Then patient-related factors: do not operate on uncontrolled diabetics. Their lids and adnexa should be free from any infection. This I've already told you. Now, pre-operative antibiotic use is controversial. Some people say that if you give pre-operative topical antibiotics, then you are probably increasing the antibiotic resistance, because then only those which were resistant to that antibiotic will be present on the surface and they are going to go in and they will not respond. So this is a controversial topic, and generally I am not very particular about giving pre-operative antibiotics. But post-operative, yes, definitely, at least in our setting, we are giving post-operative topical antibiotics for all patients, even for injection patients. Now, if at all a cluster happens, what do we do? First of all, please identify the cluster, acknowledge the cluster, accept the cluster. If you don't accept it, then you are going to have many more patients getting the same problem, and it's going to be again become a huge problem. So we do, and we are fortunate enough, Chief has made a committee. Professor Radhika is the chairman, Dr. Nishat is a member, Dr. Velpandian is a member. We have an infection control committee now, and we do have regular meetings whenever we have endophthalmitis cases, and this is what we do. We do temporarily stop the OT, and all the patients which have been done on the same day have to be called to see for endophthalmitis, because 1 or 2 might be having a very early stage of infection, and if you treat them on time, you can at least save those eyes. Then you have to review all the patient records, in what order did the patients get injected. If they are clustering together, then something happened at that moment in the OT. If the batch of the drug was changed probably for those patients, so you can pinpoint maybe where the infection is coming from. And then of course the cases have to be managed aggressively in whatever mode, whether intravitreal or vitrectomy, and we are routinely using intravenous antibiotics here and sending appropriate cultures. So it is definitely a teamwork. A surgeon, nursing staff, microbiologist, infection control team, everyone has to be involved to prevent such an occurrence. And if it does, we have to record all these cases and try to identify where the breach has occurred. So statistically, these are some alerts which have been mentioned, like alerts for COVID or other things. But I would, like I said, any case of endophthalmitis is an alert. So again, you have to analyze all your factors: operation theatre factors, movement factors, scrub factors, and patient and also documentation. So had you already documented that yes, your autoclave is working, this was the microbiological marker put and it was shown negative, this is how I do my autoclaving, this is my patient movement, this is the number of people in the OT, these are my standard practices and they are okay, then at least no one can point a finger at you and say no, you are the culprit. So endophthalmitis infection is a known complication of any surgery, it can happen, but if you at least have documented that your protocols are all perfect, at least the blame on you can be avoided to an extent. So what else? But you need to check. So you need to check from everything. You need to check even the UPS connection of the autoclaves. Sometimes they might not be working. You need to check whether the most importantly are there markers which tell you whether the autoclave is functioning or not, whether the color change or that is proper or not. Sometimes you might have bought some new batch and it might not be working properly. So each step, as a surgeon also, you need to know where the breach in sterility can happen. And yes, maintenance of all the records for all the machines. For operating room, again the ventilation and how frequently you are using bacillocid for cleaning, what is the temperature of the room, what is the humidity of the room, and what is the personal hygiene of the staff. Regularly from all surgeons and nurses there should be sampling done, whether that was being done or not has to be recorded. Satisfactory scrubbing procedure I just talked about. Then proper handling of instruments, and documentation means recording all these batch numbers and details so that if anything happens you can again go back and check the culture of that batch. So and if it happens, then again you have to recheck the sampling from the environment, the surgeon, the patient, and your bed and whatever other table or OT table and environment things which you are using, and the standard cultures would have to be sent again. If you want to prove a definite clonal link, then probably you will have to do a PCR, which we are not doing in all cases. But yes, if you have a similar organism in 2-3 patients, then probably it is same cluster. So there was also an AIOS RP Center expert committee on this, just because so many medical legal cases were coming up, and 1 or 2 suggestions which were there are that if suppose we are in practice and you have such a thing, you should inform 2 local AIOS members of your state, and then AIOS should constitute a fact-finding committee, and if they find something, an e-alert should be issued regarding whatever batch has been responsible for causing this. All this is to help you as a surgeon, so that the blame doesn't come only on the surgeon that it is because of you it has happened. It could have been because of some faulty contaminated solution or something else also. So this is something, I don't know whether it is being properly implemented, but something which could help a surgeon. And regular audit meetings is another important thing, not to hide any infection, because these are meant for learning and improving your protocols. So you must notify any infection and they must be properly handled from there on. And prevention is definitely better than cure. So what I have told you, proper practices would go a long way in preventing all these clusters. Thank you. Thank you very much.
Thank you, Dr. Rohan, for covering this very important topic so extensively, from the smallest detail to the bigger ones. So if there are any questions from the audience?
I just want to say a small extension of his talk. I think I would like to tell this important one. It was in 2015, we had a cluster in now, and before that guidelines were framed, what happened is 4 states, Calcutta, Bangalore, and one more place. At 3 places we had clustered. It was a national cluster. So all of them they contacted, because they are all having contact. Somehow our students are there in Bangalore and other places. All of them communicated us. So we got all those samples of Avastin, and we did a systematic analysis. We found some of them are counterfeit. So Avastin counterfeit is not something which is very much known to us. It was known globally. The whole supply chain was infested by somebody with a business interest came inside. So we even published a paper based on this in Indian Journal of Ophthalmology, how to identify counterfeit. So what is more important, as he said, is the source of the supply. Source of the supply. There are several channel partners through which when we get it, there is a problem. When you get the vial, the simple thing is in the OT, just shake it. So the counterfeits what we faced, we're not having the drug at all. If at all it is a protein, it should have frothing, number 1. Number 2, if you are doubting something, you put a drop of Avastin on a spatula or something which is containing spirit, or even the sterlium also. As being a protein, it will immediately coagulate. So these 2 things will make you identify and this is counterfeit or not. This is for your general information. Whenever you are trying to make that 7 syringes filled with this, you must give an emphasis on it, because in RP center, any vial comes in has been continuously checked for all things, including counterfeit, presence of, we always take the help of microbiology. Nishat madam identifies about microbe, a presence of fungus, or in case of bacteria, everything has been done. Second important thing is, don't throw the vial till the case is over. You have given the injections, keep it till everything is okay, then you dispose it. Otherwise, there could be a problem in the vial that will save you from medical legal complication. This is for inflammation.
Thank you, Dr. Pandya. So now, Dr. Radhika, please.
So now we are coming to the last lecture. It's another very important area, emerging antibiotic resistance and its significance in ophthalmology. We have Dr. Nushat Hussain, who is an expert in the field, and she will be enlightening us on this topic.
So in emerging antibiotic resistance and its significance in ophthalmology, ये हो नहीं रहा. I'll start with the spectrum of various ocular infections which we are diagnosing. So the most common infections are keratitis, accounting to 35% of the ocular infections, followed by endophthalmitis 17% and conjunctivitis 14%. 2 to 3% each are contributed by others like orbital cellulitis, uveitis, dacryocystitis, etc. And we are also doing preoperative screening of conjunctival swabs of patients posted for surgery. So this data we do not include in ocular infections per se, but the organisms obtained, the colonizers which we grow, that data we add to the understanding of antimicrobial susceptibility testing, because these colonizers only in most of the eye infections, they become the pathogens. And if we talk about the investigations of ocular infections based on the clinical suspicion of the etiology, the most common ones which we deal with are bacterial, followed by fungal, and then we also diagnose viral, parasitic and chlamydial infections. And the point to be noted here is that clinically it is very difficult to say, as I said in my previous presentation also, whether the pathogen is going to be bacterial or fungal. So 95% or more of the fungal samples which are investigated for fungal pathogen, they are also done for bacterial. And then there are many which we investigate for all 3 and all 4 of these organisms. And when we speak about microbiologically confirmed ocular infections, 78% of them are bacterial pathogens, 21% are fungal pathogens, and 1% of the microbiologically confirmed ocular infections are contributed by viruses, parasites, and chlamydia. We see a lot of mixed infections only. I am speaking about those 6 years only, 2015 to 2020. So 2 infections in various combinations were found in 34% of the cases, and 3 infections were found in 2.2% of the cases. Now we start with bacterial infections. This is again, I am speaking of the data of the past 6 years, 2015 to 2020, and we are able to see that from 11,000, more than 11,000 to 18,500 cases of ocular infections are being processed each year from 2015 to 2019. In 2020, the number of specimens processed were less because of the nationwide lockdown. And the positivity of bacterial infections, it ranges from 20% to 30% in various years. And in all the years, coagulase negative staphylococci are the most common pathogens, followed by staphylococci and Pseudomonas aeruginosa. There are some variations in the numbers and percentages over the years, but they are not statistically significant. So we can conclude from these 6 years data that coagulase negative staphylococci at 67% are the most common ocular pathogens in our ocular infections, followed by staphylococci and Pseudomonas at 13%, sorry. And these in red, these E. coli, Klebsiella, etc., these are gram-negative bacilli which belong to the order Enterobacteriales. They also form 7 to 8% of the ocular infections, whereas very few infections are caused in our setup by Streptococci, Acinetobacter, and non-fermenting gram-negative bacilli. Coagulase negative staphylococci on a routine basis we are not speciating, but in some anecdotal studies where we have done the speciation, Staphylococcus epidermidis is the most common one, followed by Staphylococcus hemolyticus and others. When we see the resistance pattern of Staphylococcus species in our infections, the good news is that whatever data we have observed, all the staphylococci, they are uniformly susceptible to vancomycin. Also, the resistance to cefoxitin resistance is a surrogate marker of methicillin resistant staphylococci. So being a tertiary care center, a cefoxitin resistance of 25 to 35% in most of the years is not very high. However, the area of concern is that to the most commonly prescribed fluoroquinolones and macrolides, most of the isolates in most of the years they are resistant. Good susceptibility, however, is seen against aminoglycosides, tetracyclines, chloramphenicol, and against aminoglycosins we are also able to see a decreasing trend in resistance over the years. In case of Pseudomonas aeruginosa, the bad news is that there is no single anti-pseudomonal drug against which all the isolates were susceptible. Also, against cephalosporins and fluoroquinolones, the resistance was very high in most of the years. Good susceptibility, that is low resistance, was seen against piperacillin, tazobactam, imipenem, except for 2019, and polymyxin B. And again against polymyxin B, we are able to see a downward trend, that is more susceptibility is coming over the years. Enterobacterials, we saw that although they form very, they contribute very low numbers, low percentages, 7 to 8% of the ocular infections. But again, the bad news here is that there is no single drug against which all of them are susceptible. And we are able to see very high resistance against the penicillins and cephalosporins and the fluoroquinolones. Some decent figures, some decent percentages were seen against the aminoglycosides, and good susceptibility was seen against piperacillin, tazobactam, and carbapenems. So it is very important that we have a look at these antibiograms time to time and decide our empirical treatment so that it is more close to the targeted therapy. And as much as possible, Microbiological investigation should be done before starting the empirical therapy, so that if there is any change in the susceptibility pattern of the organism which we are able to identify, the treatment can be tailored accordingly. Now we move on to the fungal infections. So I am presenting the data of 21 years, 2001 to 2021, and out of around 60,000 cases, the overall culture positivity was 24.6%, and in different years, mixed infections were seen from 1 to 2 to 3.7% of the cases. And in these infections, the single genus responsible for most commonly responsible for ocular mycosis was Aspergillus, accounting for 30% of the fungal infections, and these are the most common species which we encounter in our infections: Aspergillus flavus, Fumigatus niger, and others. Next is Fusarium, which accounts for 20% of the infections, and followed by that, not followed by that actually, as a group, pigmented fungi, they cause a lot of infections in our setup. So 31% of the ocular mycosis are caused by pigmented fungi, which include most commonly Alternaria, Curvularia, Bipolaris, and others. And then 9% of the infections are also caused by other hyaline fungi, especially Penicillium, Acremonium, and Piscillomiasis. These yeasts, they cause 8% of the ocular infections, Candida 7%, and Rhodotorula 1%, and mucormycosis contributes to 2% of the fungal infections in our center. If we see the trend of fungal isolates over the 21 years, we can see that this yellow graph, it is of Dematiaceous fungi, and this purple one is of Aspergillus species. So by and large, they are maintaining their top position as contributors of ocular pathogens, with a few dips and rises over the years, but they are not significant. This red graph is of Fusarium, and we are able to see that in the earlier years of the century, Fusarium was contributing to 20 to 30% of our ocular infections, but now following 2014 there was a dip, and now also they are maintaining low numbers at around 10 to 15%, low percentages. At the bottom of the graph, we are able to see that this blue colored graph, mucormycosis, and Penicillium, pink colored graph, they are maintaining their steady positions at 0 to 2% and 5% respectively. However, this green graph of Candida and black graph of Rhodotorula, this is again a matter of concern, that we are able to see a rise in these infections for the past 6-7 years. And Rhodotorula, it is an emerging ocular pathogen which we have reported from our center. AFST of the filamentous fungi we are not usually doing. However, there are some studies in which we have done it, and this is the data of 2019-20 study which I am presenting, that the 50 isolates were done, and it was found that all of them were uniformly totally resistant to fluconazole and also caspofungin and micafungin. Our Aspergillus species, they were more susceptible to, that is, they were having lower MICs against the azole group of antifungals, and the Fusarium species, they were having lower MICs against the natamycin. A similar study is ongoing right now, and here we are able to see some difference in that is, against fluconazole, all the isolates have not been found totally resistant. There is some good MIC shown by 1 or 2, and against caspofungin and micafungin also there is not absolute total resistant. There are some isolates which are showing lower MICs also. However, this is maintained that our Aspergillus species so far are found to be more susceptible to azoles, and Fusarium species are found to be more susceptible to natamycin. We have done some studies on yeasts also, and we are able to see that the Candida species, whatever infections Candida has caused, they are found to be having very low MICs against the azoles as well as caspofungin and micafungin. However, the Rhodotorula species, which is an emerging pathogen, it is found to be one of the resistant ones, and it is resistant, it is showing very high MICs against almost all the antifungals except for the azoles. We recently had one isolate of a dark yeast, a black yeast, Exophylla, and it also showed a good lower MICs against the azole group of antifungals, and it was totally resistant to fluconazole, caspofungin, micafungin, and there was high MIC against natamycin. So with this, the data which I wanted to present is over. And again, it carries a lot of significance in ocular infections. We have to start our treatment based on the local epidemiology, because we have seen presentations wherein in South India the pathogens, especially the fungal pathogens, are different as compared to the pattern what we are seeing. And also in Eastern India, the pathogens are different, the fungal pathogens. So it is, as far as possible, it is wise to use our own data to guide treatment to our own patients. And if a case is refractory, then antifungal susceptibility testing should be done, because it will tell you which drug will actually act. And as we celebrate 75 years of India's independence, I wish to everyone that we also get freedom from drug-resistant bugs in all our infections. Thank you for your kind attention.
Thank you so much, Dr. Nishad. That was a wonderful compilation of all the data and giving very useful insights. It helps for the clinicians to know what is a general pattern, and also motivates them to keep following up what happens and get this update from you. So I must say, and I'm sure everybody will agree, that it has been a wonderful experience listening to all the lectures. Before everybody sort of gets up, I thought we should have a group photograph of all the faculty, panelists, and all the ORA representatives. But one would have to agree that this has been a first and a fantastic workshop. It's good that it's the first time that we've had basic and allied sciences. And I must say I enjoyed all the lectures. Unfortunately, I had some work, so I missed a couple of lectures in between. But it has been a wonderful experience to see what is happening on the other side of the science barrier between clinical and basic. And it's very important that we should bridge this gap. And a big thank you to everybody who has been working very hard behind the scenes, Dr. Manpreet and all the ORA executives, because coordinating all the activities and preparing all the lectures, there must be so many people in the lab also who have, worked tirelessly to make this whole lecture series a success and give you the information. So we'll have a group photograph, and then Manpreet will give you an idea about what's going to happen afterwards. And I request all the faculty to please come forward, and panelists also, and also the ORA representatives for the group photograph. Come.
We have lab visits planned for all the delegates. So you can go in batches to ocular pathology, ocular microbiology, ocular pharmacology, and ocular biochemistry labs. And to facilitate the visit, we have Dr. Hemant, Dr. Ipshita, Dr. Anushka, and Dr. Ishwarya. Can we have all 4 of you near the door so that whoever wants to visit the labs and the facilities, please coordinate with them. We'll take you around in batches. Meanwhile, lunch is also ready outside. You can have lunch after visiting the labs, or if you do not want to visit the labs, you can have it now. Thank you. All the faculty is requested to please have lunch.